We welcome you all on behalf of Women in Nephrology India on the occasion of the Women's Day as well as the World Kidney Day that's coming up on 9th March 2023 with a different theme every year. Win India has taken an initiative which we had done last year as well. It was a one-week activity that we had last year, and today we come here for the Penta Day. That's a 5-day activity. We start here. The first day of our series of activities is today, wherein we are starting with the state chapters. The state chapters that we have framed and formed over the last few months, we are excited to announce that we have 6 state chapters, of which one is a zonal chapter, which they have been doing extremely well with the monthly academic activities. So we start today with our state chapters scheduled from today morning 9 a.m. onwards to till night 9:30 p.m. We have series of activities. So I request everybody to join the state chapter activities and learn and empower the kidney knowledge. So we start with Karnataka state chapter, followed by Telangana state, followed by Andhra Pradesh, followed by Tamil Nadu chapter, and followed by the Kerala chapter, as well as the Central Zone chapter. So we request everyone, whoever is joining us across the globe, as well as across the nation and across the various states, to be with us, stay tuned with us. There's more to come from us. Please learn from us. I congratulate all the state chapters, the secretaries, as well as the presidents and the coordinators who have been coordinating over the last few days for the final outcome that we are seeing today. So without much ado, I hand over the further proceedings to the Win Karnataka State Chapter, Dr. Aditya Shetty, to start the proceedings. Over to Dr. Aditya.
Good morning, ma'am. Thank you, Dr. Manjusha, ma'am, for the opening remarks for today's program. I'm Dr. Aditya Shetty, a nephrology resident at Institute of Nephrology. Today, under the aegis of Win India, Win Karnataka is organizing this online awareness program on kidney diseases on the event of World Kidney Day for general public, medical, and paramedical workers. The World Kidney Day is a joint initiative of the International Society of Nephrology and the International Federation of Kidney Foundations. World Kidney Day is observed annually on the second Thursday of March, which should be on 9th March this year. And the theme this year is Kidney for Health for All. The campaign will focus on raising awareness about disastrous events, which are natural or man-made, and the impact of people living with kidney diseases when access to appropriate diagnostic services, treatment, and care is impacted. Because of challenges in living access care in India, over 50% of patients with advanced CKD are first seen with GFR of less than 15. This highlights the need for robust screening programs for those at risk of CKD, and the reported prevalence of CKD in India ranges from around 13%. In the setting of recent pandemic and the logistic difficulties it's brought about, more emphasis needs to be placed on preparing our patients for such events in the future. With that, I'd like to move on to the first talk. The speaker would be Dr. Maitri Shankar, and I would like to invite Chairperson Dr. Renuka Satish, Professor, Department of Nephrology at St. John's Medical College, to invite the speaker, Dr. Maitri.
Good morning, everybody. A warm welcome to this special program of Win Karnataka on occasion of World Kidney Day. This year, it will be celebrated on 9th March, as Aditya has already told, and the theme of this year is Kidney Health for All, preparing for the unexpected and supporting the vulnerable. Dr. Maitri Shankar will be speaking on this shortly. So it is my pleasure to introduce Dr. Maitri. As such, she doesn't require any introduction in Karnataka, but she is one of the pillar of Win Karnataka, and she is very active in Win Karnataka group. Dr. Maitri is presently working as Assistant Professor in Institute of Nephrology, Government of Karnataka, Bangalore. She is Associate Program Director of Nephrology Social Media Collective, GLOMCON Fellowship Instructor, and Secretary Win India Karnataka Chapter. She has more than 60 international and national publications, and she is the Principal Investigator of RGHS Research Product. Over to you, Maitri, for your program. Maitri?
Yes, sir. Aditya, can you stop the screen share and we can you can introduce the other chairpersons as well.
I'd also like to introduce Dr. Sundar Shankaran, chairperson, who's a program director at Amster Institute of Renal Transplantation, Bangalore, and Dr. Padmanabhan S., chief nephrologist at Sagar Hospital, Bangalore, who are the chairpersons for this talk by Dr. Maitri.
Hello, everyone. Very good morning. Hope my screen is visible and I'm audible.
Yes, yes.
On behalf of Win India Karnataka chapter, I welcome one and all to the public awareness program. At the outset, I would like to thank Win India for organizing this event, and I would like to take this opportunity to share with all of you that Win India Karnataka chapter is now officially registered organization, and we will be hosting the annual Win India conference, that is the Win Icon, this year in Namma Bengaluru in the month of August. On behalf of Win India, it's my pleasure to invite you all to the Win India conference. Without much ado, let's kickstart Win India World Kidney Day events in association with the Win Karnataka chapter. Here is the brief overview of my talk. World Kidney Day theme so far: what is a disaster, natural disasters of India, effect of a disaster, and what is public health emergency preparedness plan. World Kidney Day was started in the year 2006 and has not stopped growing ever since. World Kidney Day is a global health campaign that brings focus to the importance of fighting kidney disease. Every year, the campaign highlights a particular theme. Last 5 years, the themes have been interrelated, that is, kidney health for all. In the year 2020, it was targeted at general population and population at high risk of developing kidney disease on how to prevent kidney disease. In the year 2021, it was targeted at patients with kidney disease on how to live well with kidney disease. Last year, it was to bridge the gap to better kidney care by health literacy. That is, to educate people without kidney disease on prevention of kidney disease, and to educate people with kidney disease on how to prevent the progression of kidney disease. This year, the theme is preparing for the unexpected and protecting the vulnerable. So let's see what this implies for us. The United Nations Office for Disaster Risk has defined disaster as a disruption on a massive scale, either natural or man-made, occurring in a short or long periods. Disasters can lead to human, material, economic, or environmental hardships, which can be beyond the bearable capacity of the affected society. The global incidence of natural disasters has been increasing, with the rate of disasters growing by at least 10-fold in one report from 1960 to 2020, with an increase in mortality, injuries, diseases, and disabilities. In 2021 alone, natural disasters affected 101.8 million people worldwide, accounted for over 10,000 deaths, and caused approximately $252 billion in economic losses. Such is the huge impact of a disaster. In the same way, at the end of 2021, 89.3 million people worldwide were forcibly displaced from their homes because of conflicts, violence, or fear of being killed in the riots and human rights violations. This is twice the number of people affected since World War II. Disasters disproportionately affect those living in developing nations or low-income countries like that of ours. For example, if you look at the Ukraine war, people from Ukraine are affected more compared to the Russians. The United Nations explains that the loss of infrastructure, such as schools, pushes the poor to fall into poverty traps during a disaster. This poverty can affect for generations together. The children and grandchildren suffer in poverty, and it can be very difficult to escape from this poverty trap. As per statistics, India as a whole is vulnerable to 30 different types of disasters that will affect the economic, social, and human development potential to such an extent that it will have a long-term effect on productivity and economic performance. The various disaster-prone zones in India are shown in this map. The blue region shows the flood-prone areas, the pink regions show the drought areas, the green region shows the cyclone-affected areas, the maroon region shows the hot desert, and the purple region shows the cool desert. Let's look at some of the natural disasters of India. The images that I'm going to show you now are very disheartening, but this is the truth, and this is exactly what we need to be prepared for. This is an image of cyclone in 1990, Andhra Pradesh, over 900 deaths. Super cyclone Orissa, 1999, more than 10,000 deaths. Tsunami, South India, 2004, over 10,000 deaths. Kashmir earthquake, 2005, over 1,400 deaths. Kosi floods, 2008, North Bihar, over 500 deaths. Maharashtra floods, 2005, over 1,000 deaths. Floods and landslides, Himachal, 2013, over 4,000 deaths. That was just a glimpse from India. Now let's look globally. Floods are the most common, affecting over 2 billion individuals from 1998 to 2017 worldwide. In 2005, the aftermath of Hurricane Katrina led to closure of 94 dialysis facilities in the Gulf Coast of the United States. Earthquakes in the Marmara region of Turkey in 1999 and Kashmir in 2005 led to a large spike in the number of patients with acute kidney injury due to crush injuries needing kidney replacement therapy. During the Marmara earthquake, 477 patients with acute kidney injury had emergency dialysis. Most of them would have died if there was no dialysis treatment available. And how can we forget the COVID pandemic? With 3 months of lockdown, where no public or private transportation was available, dialysis patients relied on the help of family and friends to travel for treatment. Staff often lived in medical units to provide treatment, and there was an overwhelming shortage of personal protective equipment. The vulnerability of dialysis patients can also be seen in man-made disasters such as war. Since the beginning of the Russian invasion of Ukraine, Ukrainian dialysis patients have suffered tremendously under the uncertainty of dialysis provisions, along with life-threatening horrors of the war. In Ukraine, there are currently over 10,000 dialysis patients and more than 1,500 people living with a transplanted kidney. More than 800 medical facilities have been damaged since the beginning of the war. Many of them are dialysis centers. Patients and staff are cut off from the dialysis centers because of missile attacks, bombardments, and active fighting on the ground. Many displaced patients and staff live directly in dialysis centers. Although it has been recorded that some of these patients died, the outcome of most is mostly unknown. This was the infographic that I created for this year's World Kidney Day. Natural disasters include floods, tropical cyclone, earthquake, landslides, tsunami, volcano. Heat wave is also common in India, and wildfire like the one just we had in Australia recently. Unexpected events such as war, famine, pandemic and epidemic such as the COVID pandemic, unexpected roadblocks can prevent the dialysis patients from reaching the dialysis center on time. This might increase the morbidity and mortality of the patient. Power is very important to run dialysis centers and automated peritoneal dialysis. Unexpected power cuts can risk the life of the patient with kidney disease. And we are all well aware that 120 liters of water is required for a 4-hour session of hemodialysis. An unexpected interruption in water supply due to pipeline damage or any other cause can again risk the life of our dialysis patients. Unexpectedly, patients with kidney disease or their caretakers may lose jobs and may get pushed into unemployment and poverty. Also, due to some unexpected reasons, patients with kidney disease may lose their caretakers and they may not know what to do. So now when we say vulnerable populations, for us, it includes patients with acute kidney injury, patients with chronic kidney disease, patients on dialysis, transplant patients, patients with comorbidities such as diabetes, hypertension, autoimmune diseases, elderly, women, children, and those with disabilities. Now let's look at the effect of natural or man-made disasters. The effect can frequently be felt physically, mentally, and emotionally at the individual level. Property is destroyed, financial resources are lost, and individuals are injured or ill as a result of these natural disasters. In less developed nations, massive migration of people can occur because of lack of resources, lack of safety, and lack of shelter. Numerous individuals develop severe post-traumatic stress disorders or withdraw into depression following a natural disaster. Disruptions to transplant services is well known. Transplant services are often suspended in times of crisis, which leads to added stress on the healthcare system. This was certainly the case for many countries in the early stages of COVID-19 pandemic, with suspensions of waiting list activation. Also, access to essential immunosuppressive medications for kidney transplant recipients is often disrupted during disasters. This directly increases the risk of rejection and allograft loss. Governments have a responsibility to uplift the vulnerable population during disaster response and help in recovery to ensure that whatever inequalities are already existing, it does not get increased or amplified because of this disaster. Because the most common people that are affected are the ones that are below the poverty line, socially discriminated, or racially discriminated. You have now seen the kind of impact it has on people and resources. With such huge impact, there is a clear need to better plan and be prepared for disasters of all scales in an attempt to minimize the effects of the disasters. This World Kidney Day, we urge the patients, their caretakers, physicians, policymakers, public and private sectors to have a preparedness plan, which includes patients with kidney disease. The government already has a disaster management plan in place, but this does not include patients with kidney disease. So what are the lessons that we learned from COVID pandemic? 3 important lessons. We have to strengthen our national health systems and increase investment in primary healthcare and public health. Second, we should have national pandemic preparedness plans. And third, we should have adequate financing for sustainable development and have green recovery plans. The governance and leadership should make sure that structures are integrated both vertically and horizontally. When we say vertical integration, it means that the referral systems should be in place. Referral from PHC to a district center, followed by a tertiary care center, should be with proper communication, proper protocols, and proper transport system in place. Horizontal integration means referral from one primary healthcare center to another, from one dialysis unit to another, or a tertiary care center to another. So there should be adequate communication and protocol in place, as already mentioned, for horizontal integration as well. And many layers of the healthcare system should be connected. The supply chains to the hospitals and dialysis units should be intact with minimal or no disruptions during disasters. Power backup or plans to minimize loss of electricity during disasters should be in place. There should be a strong partnership between the essential areas in health and non-health sectors, such as power companies and supply companies. We need to have a strong tie-up with the power companies and supply companies at the time of disasters. Roles, responsibilities, relationships, engagements, and organizational structures should be clearly defined in the planning process itself, so that there is no confusion or chaos among the stakeholders at the time of crisis. Collaboration supports readiness, response, and recovery through various levels in the system. And this collaboration includes physicians, emergency care physicians, emergency care management, non-governmental organizations, or the private sector. For example, if you want to refer a patient from a public hospital to a private hospital or vice versa, during the time of crisis, it should be smooth with no hiccups. We should have interconnectedness, not just within the public healthcare system, but outside as well. Both public and private sector should work in unison at the time of crisis. It is very important to engage the community at the time of crisis. It promotes inclusivity and improves the community understanding. Community risks, community assets, and their values should be incorporated in the plan. There should be transparency and trust between the government and the community. So if the community trusts the government, this will reinforce the strength of the entire system. During a disaster, everyone is in panic and fake news can spread like wildfire. Disseminating accurate and accessible information to the public is very important. Governments and organizations can reduce the spread of disinformation or fake news by working with social media companies to invest in development in some sort of algorithms that can identify fake news and to make strict policies that will bring down or strike down fake online accounts or malicious accounts. We should train patients on self-care at the time of crisis, such as preparing medication kits, keeping medical records in a safe and ready place, keeping a first aid kit ready, keeping emergency contact numbers ready. All patients should keep an ID card that has their diagnosis, blood group, and drug allergies list. Continuous ambulatory peritoneal dialysis is better during disaster as it does not require any power like an automated peritoneal dialysis or hemodialysis. Self-care and preparedness is of critical importance during times of disaster. Risk analysis. It is important to understand the risks for the communities. Risk analysis strengthens planning and decision-making. We should analyze the existing social risk factors such as poverty, disabilities, or morbidities someone may have before a disaster. So this might put them at a higher risk, and this population would be more vulnerable. This applies to patients with kidney disease as well, be it chronic kidney disease, acute kidney injury, dialysis, or transplant patients. They all belong to vulnerable population, and plans should be in place to protect the vulnerable population first at the time of a disaster. Constant surveillance and monitoring is very important to provide information or key alerts to the key authorities and also to the community. The main element of surveillance and monitoring is early detection and early warning of alerts of emerging disasters to the relevant health authorities. We should make sure that all the data sets are linked, like the electronic health records, drug utilization records, and community health records are linked together, and they are constantly under surveillance and they're constantly being monitored at the time of disaster. So we have so many things in place, but if there is no practice, then we don't become perfect. Practice and experience includes exercises, simulations, drills, and practice to build capacity for response and feedback. And also practice tests and plans will identify the gaps and weaknesses in our plans and will help our plans get better. Workforce capacity is critical. Well-trained and knowledgeable staff form the backbone of the social infrastructure. So staff education and training and preparedness is very important. This includes how to support the patient needs directly as well. Communication should be very clear and consistent with understandable information to create awareness across the networks and the public to deliver information. If you want any public action or behavior change, like for example, using sanitizer, wearing mask, maintaining social distancing. So you have to communicate and be clear, and it should be consistent. One minister should not give one information and another minister contradict the same information. It should be, the information should always be consistent, even if it is providing guidance for the healthcare workforce. The message should be clear and preferably local language. Optimal use of social media is also important with relevant messaging that should be planned early to counteract false messages. Learning is usually flexible during emergencies, and it is connected to surveillance and monitoring. A critical aspect of learning is thorough understanding of patient perspective towards disaster. One study looked at patient thoughts during disaster and found that the major concern was feeling unprepared and concerns with managing one's disease. This World Kidney Day, we have to urge our policymakers to integrate patients with kidney disease in preparedness plan. Here is a short video which you can see. Just show you. So you can see here that how unexpectedly kidney failure, kidney disease affected baby, and poverty and unemployment had literally forced her to stop dialysis. So the government has to play an active role here and protect vulnerable population. Baby falls under the vulnerable population category. So this is the infographic which I prepared, which I had mentioned earlier, summarizing the World Kidney Day theme for this year. Steps for public health emergency preparedness include governance and leadership active role, planning roles and responsibilities, collaborative network, engagement of the community, analysis of the risk of poverty, disabilities, and morbidity, early detection and warning, practice sessions, mock drills, resources, physical resources, structural resources, financial resources, optimal use of social media to bring down fake messages, learning and evaluation. Thank you for your time.
Thank you, Thank you, Dr. Maitri Shankar, for your talk on preparing for the unexpected and protecting the vulnerable. I'd like to request the chairpersons for this talk to please express their view on this topic.
Maitri, at the outset, I must say that you covered a variety of topics, variety of headings in the short span of time. Disaster is something which we don't look at in the normal period. When we are normal, actually that is time we should be prepared. Like COVID, we never thought COVID occurred, but it taught us a lot of things. And if we look at history, the dialysis machine was invented because of the disaster of World War II, because of crush injuries. So we learned from disaster, and I learned from a Japanese colleague before WhatsApp during the earthquake. They had some apps which actually helped them to save patients go for dialysis. I think now you have done a lot of work, and you speak on artificial intelligence apps. Do you think they have a role now in helping us in disasters?
Definitely, sir. Artificial intelligence can always help us in surveillance and monitoring, help us give early warnings and early alerts, so that the information is passed on to the relevant health authorities, stakeholders, and the community as well. Also, these apps or artificial intelligence can also help in identifying fake news, fake accounts, malicious online content, because people are already in panic. So there should not be any spread of false information or misinformation. So artificial intelligence definitely has a very huge role to play.
Thank you, Maitri.
Dr. Maitri, it was a very lucid presentation, as you do it always. I mean, what strikes me is that when you look at the non-communicable diseases, the 4 things that stand out according to governments, not only in our country and across the world, is cardiovascular disease, diabetes, cancer, and chronic respiratory illnesses. But I don't think they form the majority of the non-communicable diseases. I think it is probably the other non-communicable diseases, of which chronic kidney disease stands out, which accounts probably for around 50-55% of non-communicable diseases. But unfortunately, I think that is not included in the agenda of most governments across the world, including ours. I think the hint that we need to take is that COVID has exposed inadequacies of the healthcare system all around, and our lack of preparedness when there is an emergency of such a huge magnitude. So I think this is the time that the Indian Society, the International Society of Nephrology, the regional chapters, and whatever it is, should take a collective role and then try to probably impress upon the government that you need to take chronic kidney disease very seriously, because unfortunately, we don't have any cure for that disease. So if we let the disease progress to end-stage renal disease and then allow for dialysis and transplantation to occur, then I think that would be a huge drain of resources, which I'm sure we cannot afford as a nation. So I think this is time, and probably this is the right platform where we should all get up and say that, look, let us talk about chronic kidney disease, and let us include this in the non-communicable diseases program, and then make it quite popular. I think that is what we should do. And this has given us an opportunity. This World Kidney Day has given us an opportunity to probably highlight this particular issue. And then you tell them that we have seen all these things happen during the last 2.5 years when COVID was at its peak. I think that is what, as a community, I think we should all do. Hope all of you would agree with me.
Definitely, sir, definitely.
So Maitri, it was an excellent presentation and congratulations.
Thank you, ma'am.
Thank you.
Thanks. Thank you. Thank you very much.
Thank you, dear chairpersons, for sparing your valuable time with us.
I thank all the chairpersons for their valuable insights into this topic, and Dr. Maitri Shankar for having delivered that talk. I think we can move on to the next talk, which is how to prevent CKD in children by Dr. Saurabha Rajanna. I'd like to invite the chairpersons for this topic, Dr. Shankar Prasad, Professor and HOD, Department of Nephrology, KMC Manipal, Dr. Anil Vasudevan, Professor and HOD, Department of Pediatric Nephrology, Dr. Sanjay Srinivasan, Chief Nephrologist and Transplant Physician, Department of Nephrology, Suguna Hospital, Bangalore. I request Dr. Anil Vasudevan to introduce Dr. Saurabha Rajanna.
Good morning, all. At the outset, thank the WIN team and Saurabha for your kind invite. I have the pleasure of introducing Dr. Saurabha, who finished her nephrology training from St. John's Medical College Hospital, and now is a faculty at JSS Medical College Hospital. She's also the recipient of the Blomkorn Fellowship. Academic activities, and well known for a passionate
Thank you, sir. I'll just share my screen.
Dr. Can you unshare the screen so that's sort of.
I have unshared the screen.
Hope my slides are visible and I'm audible.
Yes, ma'am.
Yeah. So at the outset, I would like to thank WIN India for providing this platform. We have a series of 4 lectures based on simple topics and addressing mainly prevention and primary management care in CKD. So the first talk in this session would be chronic kidney disease and prevention in children. So chronic kidney disease, basically as defined by KDIGO, would relate to either a structural or a functional damage to kidneys and lasting for more than 3 months. Now, why are we so bothered about pediatric CKD? Apart from the age-specific implications, we now also know that most of the adult CKD, the origin probably lies in pediatric origin, what is known as fetal programming and the different environmental exposures over their life course. So to quote John Connolly, for in every adult there dwells the child that was, and in every child there lies the adult that will be. Focusing on pediatric kidney diseases provides us a window wherein certain high-risk events in the adults can be avoided, and therefore the burden of adult CKD can also be brought down. Now, if we look at the global scenario, of prevalence of pediatric CKD. The data is predominantly from the Western countries. This is because of lack of national registries, and even among the registries, the definition of CKD, there have been varying definition of CKD. And so this is actually an underestimation. The rough estimates quote somewhere between 15 to 70 per million population of kids are affected with CKD. Data from India vastly remains unknown, but is estimated somewhere close to 70 per million population. Now, the rate of kids who require dialysis support in the end stage is also dependent on the regional and national practices, when dialysis was initiated, what was the criteria used to enroll them to studies and such. Basically, it is around 20 per million population in under 20 years where ESRD was diagnosed and dialysis initiated. But this is not similar across the globe, primarily because of disparities in access to care and affordability and such factors. So knowing this, let us slightly dwell on the topic as to why we have to focus on childhood or how it is different from adult kidney diseases. First and foremost, we should understand that the spectrum of childhood kidney diseases is different as against the adult kidney diseases, where hypertension and diabetes form the major chunk of kidney diseases. What happens in childhood kidney diseases is it is predominantly the congenital abnormalities of kidney and urinary tract, which are responsible for end-stage renal disease or CKD. And also the initial programming in the fetal life, wherein we were speaking about the number of nephron, contributes to CKD as we progress in age. So an individual born with a lesser number of nephrons or with an abnormal size of a nephron, when exposed to similar set of environmental toxins or exposures which can lead to kidney diseases, respond differently as compared to someone who did not have those perinatal implications. This is another picture where we can see that majority of the adult diseases have their antecedent factors based from the childhood or perinatal factors. And of course, the pediatric CKD is associated with significant morbidity and mortality. Mortality among children who progress to end-stage kidney is estimated to be 30 to 50 times higher compared to the general population or their peers. And as we already emphasized, there is grossly unequal access to care, and particularly renal replacement therapy in terms of pediatric CKD. In addition to this, there are problems which are specific to LMIC country like ours, where the delays in diagnosis are common. There is increased burden of comorbidities, or protein energy malnutrition is much more common. There's poor access to healthcare. There's higher financial burden of treatment and lack of social support. Recognizing this particular problem, the ISN way back in its 11th campaign in the year 2016 had the theme specific to children, kidney disease and children, act early to prevent it. So now that we know the implications and the burden of pediatric CKD, how do we go about to prevent it? So prevention of kidney diseases in childhood can be at different levels. Primary, wherein we eliminate or reduce exposure to factors that cause kidney disease. Secondary, where we prevent progression of chronic kidney disease. And tertiary, where there is reducing or postponing the CKD complications and prevent them into going into end-stage renal disease. So ideally, when do the primary preventive strategies have to be implemented? For any disease, primary prevention is the most ideal. The primary prevention should start much before pregnancy. In fact, in the anticipant mother, control of factors which lead to metabolic syndrome, avoiding drugs in the periconceptional period, folic acid, which can supplementation, which can bring down the neural tube defects and thereby the bladder or the voiding issues. Genetic counseling, when indicated or when there is a family history, would address these issues much before pregnancy. During pregnancy, avoiding teratogenic drugs, intrauterine infections can go a long way. Periodic antenatal ultrasound to recognize congenital abnormalities and suitable interventions wherever possible. Prematurity, we all know, is related to lower number of nephrons. And although we might not be able to totally eliminate prematurity, reducing risk factors in the anticipant mother by treating UTIs, better control of blood pressure would bring down premature and low birth weight babies. In infancy, there are studies which suggest that breastfeeding as against the artificial feeds are associated with better weight gain and also preventing obesity later in life, focusing particularly on infant nutrition. In NICU graduates, particularly avoiding exposure to nephrotoxic medications, be it aminoglycosides or diuretics or contrast agents, could be avoided in high-risk babies, and screening them at periodic intervals would help us pick them up early. Now, in childhood and adolescence, the approach is slightly different, wherein it is a disease-based approach. Preventing or if not prevention, early treatment and management, appropriate management of glomerular diseases, treatment of urinary tract infection, preventing any cause of AKI, because sepsis is more common. Sepsis and possible AKI could be avoided, like a child with dehydration in cholera or such scenario, where an adequate hydration would itself bring down the mortality and morbidity rather than emphasizing basic hygiene. Cautious use of drugs and contrast agents, and prevention of adolescent hypertension. There's this phenomena of tracking wherein the childhood blood pressure progresses to adulthood hypertension. Lifestyle changes, education on food awareness and what to choose, preventing obesity and dyslipidemia, prohibiting use of illicit drugs, smoking are all certain preventive strategies which can be employed to prevent kidney diseases in the adolescent group. Now, as emphasized, primary prevention, although ideal, may not always be feasible. And we have to have a mechanism wherein we identify children with chronic kidney diseases early. So how do we identify them early? We have to screen, and then we have to also take measures to retard progression of CKD. We all know that serum creatinine being used as a marker of CKD, it is a late marker. In addition, this comes with the caveat in pediatric age group because of the lesser muscle mass. They would probably also be having a coexisting protein energy malnutrition, and usage of formulas are also having their own set of hindrances. So what is probably which can be used as a mass screening measure would be urine analysis and blood pressure monitoring. An ideal strategy would probably involve a focused physical examination and an initial urine dipstick. If found to be abnormal, a formal urine analysis and a basic chemistry panel and a detailed evaluation, if indicated, would help us in picking up the majority of pediatric CKD. Now that we have identified a screening tool, whom to screen? There have been mass strategies like emphasizing CKD screening at schools, as in Japan. But in a country like India, wherein the population and the health resources are not at par, we have to identify high risk and employ the screening tools at least on them. So population which is at high risk for pediatric CKD would be those who were having an antenatal USG where a genitourinary abnormality was detected, low birth weight and premature babies. AKI as a continuum can lead to CKD or due to any cause, and neonatal AKI of particular mention. There have been studies suggesting the same. Children with family history of kidney diseases or history of urinary tract infection and voiding dysfunction. Any abnormal appearing urine needs to be investigated. Drugs exposure, which are known to affect kidneys, And because childhood CKD is often non-specific or silent, certain features like when the kids present with failure to thrive or bony abnormalities, they need to be evaluated for an underlying CKD. That said, now that we have picked them up, how do we retard the progression of CKD? Conventionally, the progression of CKD has been related to modifiable risk factors and non-modifiable risk factors. Focusing more on modifiable risk factors, we have protein leak and hypertension, anemia, and dyslipidemia. There was a recent study also, which was published in KI reports in 2019, where proteinuria and uncontrolled hypertension, or a combination of these factors, were the major modifiable risk factors for progression from our country too. A special mention here on the ACE or ARB inhibitors, which has also been proven by the ESCAPE trial, known to retard the progression of CKD. But very few children reach the nephrologist at a level where AC or ARB can be initiated, or there would be other factors like increase in potassium or worsening GFR, and where we will not be able to use such drugs to the extent recommended. The other factors which can be addressed in prevention of CKD would be relief of any obstruction, use of adequate immunosuppression to achieve the control of an underlying glomerular disease, hypertension and proteinuria as already emphasized, and relatively try to prevent the infections of urinary tract, hyperlipidemia, and reduce the risk of exposure to nephrotoxic medications. Now, when we speak about tertiary prevention or CKD management, apart from the conventional management of acidosis, CKD, MBD, anemia, and cardiovascular complication, what deserves special mention would be vaccination and nutrition. Nutrition, particularly in a growing child, supplementation of adequate protein, or if the child has been on continuous ambulatory peritoneal dialysis, provision for additional protein, prevention of vaccine preventable diseases and thereby recurrent hospitalizations, catabolic state, would all help in prevention of or progression of CKD stages. When the child does reach renal replacement therapy, we have the options of kidney transplant, peritoneal dialysis, or hemodialysis. Kidney transplant, of course, is the best modality, however, is limited, is not easily affordable. The technical expertise to perform a pediatric renal transplant is not very well established even today. So that said, and how do we prevent other strategies so that CKD can be prevented? When we were speaking about the community engagement and the decision at the policymakers, there is a program by International Society of Nephrology, which emphasizes adequate treatment of AKI in the early stages, particularly in low resource settings, wherein acute PD can be employed and AKI treated adequately. This is also tagged to the ISN's 0 by 25, 0 deaths due to AKI by 2025 tag, wherein the primary points have been raising awareness of AKI among medical community, training and educating, a tailor-made training and education of the medical personnel, and advocating for access to early care of AKI. This, in fact, the Saving Young Lives project by ISN has gone a long way and has helped prevent or bring down the progression of AKI or achieve adequate treatment of AKI in early settings, in resource limited settings. When we say or when we speak of pediatric CKD, it is mostly dealt with a general pessimistic attitude because the majority of them are congenital abnormalities. Nothing more could be done, sort of a scenario. But the scenario is slightly changing and maybe more optimistic than before, particularly with the advent of newer drugs. In fact, the not so new eculizumab in atypical HUS has been a game changer. Though there are disparities in the accessibility and enormous cost have been some hindering factors, we hope to be able to overcome that in some time in future. The other example would be probably vasopressin antagonists, which have seen their role in ADPKD. Whether similar drugs could be used in the childhood or the pediatric diseases is something which is ongoing studies. And with us moving on to the precision medicine and advances in genetics, which lead to early diagnosis and probably early therapy or modifiable factors with epigenetic modifications, which could prevent pediatric CKD, are also in the pipeline. So pediatric CKD, everything said and done, although might not be completely preventable, focusing on simple hygiene measures or early screening and preventing the progression can go a long way, not only in bringing down the mortality and morbidity due to pediatric CKD, but also in preventing adult CKD or bringing down the load of adult CKD. Thank you for this opportunity. And if there are any questions, I would be happy to take.
Thank you, Dr. Saurabha, for that talk. I'd like to request our chairpersons to please share their opinion and their views on this topic.
Dr. Prasad, Dr. Srinivas, if you have any comments, then I will follow it up.
Dr. Saurabha, that was a very nice, in detailed evaluation of what you can do. And as you said, one of the important thing is when the patient has AKI, he recovers, and usually we tend to forget. So it is very important that any patient, whether it is adult or a pediatric population, once the AKI is recovered, at least once a year evaluation of the renal function plays a very important role. Because you have mentioned that in your talk, that is, it is important. Second thing is there are certain myths within the society. Whenever there is blood in the urine or the baby complains of dysuria, usually they label it to, I don't know how they explain, the heat in the body, or they say Ushna in Canada. So that myth has to be broken down. And even in the pediatrics who are treating the UTI, they should just not treat the UTI. They should look at the reversible causes for this UTI. In majority of the cases, simple things, there may be reflux. There may be simple things in male child, like phimosis, there can be pinhole meatus, which are correctable. So this I'm telling you because I had done one survey of one of the schools from 5th standard up to 10th standard, around 500 plus students in a suburban school, which is not of a very high class. Out of 500 plus students that I evaluated just by doing, as you said, the urine routine and the blood pressure monitoring. And I found that almost 121 of them had some kind of problems which may translate to CKD in the future. That is a huge number. That comes to approximately 20+% of the students. So it is very important that we go ahead and evaluate these students. The screening is very important. So as you said, any CKD which is happening in the adults, the seeds are sown much earlier, probably. So it was a good talk, and it has covered almost everything. Other panelists who want to put in a word can do it. Thank you.
Congratulations, sir.
Thank you, sir.
We emphasized the prevention starting from pregnancy itself. And my thing is, what's your comment on, sir has also told Sanjay sir about screening, about education in the schools. What do you think, your comment, your inputs?
It would be, if applied, it would be great, sir. It's a great strategy to have screening strategies employed in school. It's much more feasible wherein we have a accessible population. A simple urine dipstick would easily pick up the diseases much earlier, much before they present with the problem to the clinicians and later being referred to a nephrologist. But the problem lies in applying the screening tools to the vast majority of schools, maybe the public schools, or and which age group to be targeted, how frequently should the screening be applied. So such logistic or issues, if addressed, it would be indeed a great strategy.
Over to you from our side. Yes.
Yeah. So thank you, Saurabh, for that very short and sweet talk on the prevention. And I think we are all trained to be curative and palliative therapists, and prevention somehow takes a little backseat in a busy practice. And I think two components which I wanted to highlight was, one is education and awareness at 3 levels. One is of the family. For example, if there is a strong family history of Kakut, I think it becomes very important if they have other young adults who are soon to get married, to discourage them from getting married to their own relatives, even if it be distant, unless there is a proper genetic counseling. The second level is among the first contact of children. That is, they are invariably the pediatricians and primary care physicians. So such as Dr. Srinivas said, helping them create awareness about how to diagnose UTI and what evaluations are required. And also a lot of syndromic signs that a pediatrician may see it, but may not connect it with a kidney disease, like a simple ear tag, a single umbilical artery, a developmental delay itself can be a harbinger of an underlying association with Kakut. So creating this awareness to pick up these children for additional evaluation becomes important. And third is probably our own community of nephrologists and pediatric nephrologists, probably diagnosing right, and also the appropriate medications, because pediatricians are not pediatric children, or children are not young, just young adults. So the management protocols and all that, the standard of care needs to be applied. And the second often underused tool is the genetics. Considering that 2/3 of the children, especially young onset, have CKD. I get sometimes surprised when we see children where the family is not aware that it can recur in the next pregnancy, and monogenic, be it a distal RTA, ARPKD. So I think we need to use the genetic testing that is easily now available, less costly for these primary preventions of those which invariably go into ESKD, such as ARPKD, oxalosis, and so on. And the third is probably the policy. I think we are not strong enough to advocate the government to have therapy for the rare diseases, such as cystinosis. We don't have cysteamine at all, which can relatively improve the quality of life. And similarly, some other rare drugs that are available. And so I thank Saurabh again for the nice talk, and I thank the WIN team for organizing this event.
Yes, I want to put in one more thing. What I have been educating at my hospital wherever I practice is any newborn, before they are discharged, I think they should have one urine routine, they should have one ultrasound abdomen, and they should have urea creatinine check done. But not everyone follows that. But I think it should become a routine trend.
Yeah, we have the anomaly scans, but many of the time those subtle signs in the anomaly scan are often ignored. Yeah. So probably creating, as you said, awareness and education of these primary contacts, be it radiologists, obstetricians, pediatricians.
Yeah, thank you.
Thank you.
Dr. Saurabh, there are 2 questions in the chat box. One is antibiotic prophylaxis in UTI and Kakut can be of any value or not?
I don't think.
By Dr. Hamdi Ramadan.
So routine antibiotic prophylaxis in Kakut per se would not be indicated. If there has been a recurrent UTI, as per the guidelines, when evaluated and found, there have actually been the trials wherein Reboot trial and everything, which emphasize that antibiotic prophylaxis routinely may not be of value. Any difference of opinion, Anil sir? Would you say that antibiotic prophylaxis?
Yeah, I mean, the way we use antibiotic prophylaxis has much become more conservative. Like you rightly said, we no longer use antibiotic prophylaxis if there is an antenatal hydronephrosis without symptoms or in Kakut. Now the indications are very clear. I mean, the most recent UTI guideline from ISPN will come in 1 or 2 months, where we have refined this antibiotic prophylaxis. Now antibiotic prophylaxis is required only in high-grade reflex, that is 3, 4, and 5. For at least 2 years from the time of diagnosis, or at least 1 year of UTI-free period. You can continue the antibiotic prophylaxis if the bowel bladder dysfunction persists until they are toilet trained. In the low-grade reflux, there is no role of antibiotic prophylaxis unless the child has bladder bowel dysfunction. So these are the new that will come up in 1 or 2 months in the newer guidelines.
The other question is about the amount of water and CKD progression?
So water type per se, the amount of water the child has to ingest would be related to the underlying kidney disease, whether interstitial or glomerular disease, and the stage of CKD. Water intake as regarding CKD progression is probably not much useful in pediatric CKD. That amount of water intake and CKD progression is probably from the adult ADPKD guidelines, wherein the trials wherein additional water in CKD stages 1 to 3 in ADPKD suppresses the cyst growth. But that said, there is no specific role of additional water intake or restricting water intake and CKD progression in kids.
Thank you, Saurabha, for that wonderful presentation. I thank our chairpersons, Dr. Shankar Prasad sir, Dr. Anil Vasudevan sir, and Dr. Sanjay Srinivas sir for sharing their insights and valuable time with us. Thank you so much, sir. Over to Dr. Aditya.
Thank you, chairpersons, for your insights. The next talk would be on how to prevent urinary tract infection by Dr. Suma Raju. I'd like to invite the chairperson, Dr. Sridhara CG, HOD, Department of Nephrology, Institute of Nephrology, Bangalore, Dr. Topoti Mukherjee, Lead Consultant Nephrology at Astor Whitefield, Bangalore, and Dr. Pooja Prabhu, Assistant Professor, Department of Nephrology, MS Ramaya Medical College, Bangalore. I request Dr. Topoti Mukherjee to invite Dr. Suma Raju and introduce the talk.
Am I audible? Good.
Yes.
Good morning, everybody. It gives me a lot of pleasure to introduce Dr. Suma Raju as a speaker for the next topic. Dr. Suma Raju is a leading senior nephrologist in Narayan Rudayalaya HSR layout. She is American board certified in nephrology, and she has a lot of experience in the field of nephrology. She will be enlightening us on the management of the non-antibiotic prophylaxis of urinary tract infection. This is something that we as nephrologists deal very frequently, and I must say helplessly, in recurrent UTI. And Dr. Suma Raju will educate us on this topic. Over to you, Dr. Suma.
Thank you, Dr. Topoti. Good morning, everybody. So I'm here to discuss about the preventive strategies in urinary tract infection, focusing mainly on the non-antibiotic measures. So urinary tract infection is one of the most common bacterial infection worldwide, and it affects about 150 million people each year worldwide. It's a most common cause of nosocomial infections as well, and it results in a considerable patient morbidity and large financial burden. It's approximately 25% of all antibiotic prescriptions are for UTI in our practice. And that shows that it's a growing risk for antimicrobial resistance as well, given the way we prescribe antibiotics for UTI. So if you look at the incidence of UTI, if you look at this, 50% of all women will have UTI in their lifetime, out of which nearly 20% will have another UTI. And out of the 20%, 30% will have recurrent UTI, and 80% of all those will have frequent UTI thereafter. The incidence is really high with the recurrent UTI. And for simplicity purposes, I'm just dividing urinary tract infection into cystitis, which is infection of the lower urinary bladder and the lower urinary tract, and pyelonephritis, which is infection of the kidney and the upper urinary tract. So let's look at some prevalence of the uropathogens. Most of the studies are done at the international level. In our Indian scenario, there was a recent one published by the microbiologists in the Journal of Microbiology in 2022, where they looked at the prevalence and resistant patterns of uropathogens in the community across all parts of India. So if you look at that, in North India, South India, East India, and West India, if you look at the most common organism is E. coli, constituting about 68%, and followed by Klebsiella proteus. And it kind of correlates with ICMR data as well, where it says that E. coli is the most common uropathogen. And if you look at the antimicrobial resistance pattern, you see that almost 70 to 75% there is resistance to fluoroquinolones, beta-lactamases, ESBL producers as well, and first and second generation cephalosporins. That kind of leaves us with this, look at the sensitivity pattern. We are left with aminoglycosides, carbapenems, and tigecycline. And nitrofurantoin. The sensitivity, we have very few antibiotics left actually. So looking at this, definitely there is a need for non-antibiotic management, which we have to look at it. And why is it so? Because basically the armamentarium for effective antibiotics is diminishing. And there is widespread emergence of carbapenem resistance. And there is also transmissible resistance now to colistin as well. So before we go into this, let's look at what is the natural defense we have against UTI. Actually, our human body is well designed to protect ourselves from any infection. So by, the urethra itself, it acts as an obstacle to intravesical inoculation. In females, the urethra is short, which makes them more vulnerable to UTI. And the physicochemical characteristics of urine, based on its pH and organic acid content, it is not conducive for the bacteria. And the act of urination itself, it eliminates most bacterial population. And the presence of urinary glycoproteins, such as Tom Horsford proteins, they act as soluble receptors and enhance clearance. There are also inhibitors of bacterial adhesion, such as mucopolysaccharides, and the presence of lactobacilli. This is very important. They actually protect us so much because they have a local bactericidal effect, and they actually prevent this uropathogenic E. coli from entering and protect us most of the time from UTI. And there's constant exfoliation of infected urothelial cells. So we have so many different mechanisms to defend against UTI. Any imbalance in these actually causes the uropathogenic E. coli to go up and cause a UTI. So let's look at how it does. So anything which disrupts this balance causes the bacteria to go up into the bladder. We see that usually the uropathogenic E. coli is colonized around the rectum. So when it gains access to the urethra, when the host defense mechanisms fail and it lets the bacteria to go inside the bladder, what happens is the bacteria along with the pilus attaches to the urothelium, enters inside the cell, forms intracellular bacterial complexes. They multiply there. That leads to efflux, and this causes infecting the neighboring urothelial cells, and they gain entry into the transitional cells, and they form a reservoir, and constantly they give rise to this relapses, and they become quiescent over there, causing reinfection most of the time. They remain quiescent there. So let's look at some of the non-antibiotic agents which have been studied in preventing recurrent UTI. First and foremost is the behavioral changes. And let's discuss phytotherapy, plant-based medicines. The others in the line are probiotics, D-mannose, methenamine hippurate, estrogens, intravesical glycosaminoglycans, immunostimulants, and vaccines. Let's look at how they work and what evidence is there for them in our as we go on in the talk. So behavioral measures, wiping from front to back, that makes sense. As we told, the rectum is colonized by the uropathogenic bacteria. You don't want to wipe from back to front, which will increase the colonization of the harmful bacteria. So wiping front to back eliminates cross-contamination. That is something which people need to follow. And avoid douching and using scented products like sprays. What they do is they kill the healthy bacteria, the lactobacillus. The vagina is colonized by these healthy bacteria, which prevents us from getting UTI. So when they use these scented products, they kill the lactobacillus and encourage growth of the harmful bacteria. So this kind of disrupts the balance, and they're more susceptible for developing a UTI. So The other thing is avoid holding your bladder for too long. When you have the urge to urinate, you have to urinate. The urine in the bladder acts as a medium for bacteria to grow. So these are all based on observational studies. There is no large trials that have been done to study this, but the consensus is that, you have to pass urine every 3 to 4 hours, which would minimize the bacterial overgrowth. And next one is urinate before and after sexual activity. As you see, during sexual activity, the urethra could be damaged a little bit. That will, aid the uropathogenic bacteria to enter into the bladder. So what they recommend is peeing before and after sexual activity, which is the main idea is to flush out the bacteria. The next is people using birth control. Spermicides and diaphragms, they contain this chemical called nonoxynol 9, which destroys the good bacteria, the lactobacilli, but it doesn't kill the uropathogenic bacteria. So this kind of disrupts the balance, and the uropathogenic bacteria grow and gain access to the bladder. So people who are using the birth control option should consider switching if they have history of recurrent UTI. Hydration. The much talked about thing like how much to drink and how much not to drink. Hydration basically dilutes the urine and makes you urinate more frequently, and in turn helps you flushing out bacteria. So this hydration, all the studies dates back 30 years ago, only observational studies, where there were some studies which looked at restricting fluid intake in one group and not restricting. Those who had restricted fluid intake showed increased incidence of UTI. They were all small studies, and in none of the studies the optimal fluid intake was mentioned. So the general consensus later came up, a daily target of 2 to 3 liters per day is probably beneficial. But again, this applies to specific patient populations. We see people with heart failure and CKD later stages. For them, this may not apply. So here, this should be interpreted with caution. For the healthy premenopausal women, maybe we could recommend daily target of 2 to 3 liters per day. Coming on to phytotherapy. The Chinese herbal medicines were studied. 2 products, Huang Lian and compound salvia granules. There were several studies done, and it showed that it probably prevents recurrent UTI. And a Cochrane review was done on 7 randomized trials, but they found that they were all small studies that of very low quality. There was a high risk of bias, and the safety profile was not established. Hence, they are not recommended at this point. The other thing is cranberry products. I guess everyone knows about cranberry products now, and many of you may be using it. And how does it actually work? So cranberries initially thought it was because of the acidic nature that it helps in preventing UTI, but later in vitro studies showed that it contains fructose, which inhibits adherence of E. coli with type 1 Fimbriae. And the other chemical is which cranberry contains is proanthocyanidins. And these have an A-type linkage along the polymers, and that is the one which actually inhibits adherence of P-fimbriated E. coli to the urothelial cells. The other juices such as grape juice, apple cider, green tea, they all may be acidic, but they have a B-type linkage, which is not very beneficial. This is where cranberry juice has an advantage that it inhibits adherence of E. coli due to this A-type linkage. So look at the evidence here. There are several studies which have been done with cranberry, and they use juices and some powders and extracts were used. And they basically reduce adhesion and motility and prevent biofilm formation. And it impacts uropathogenic strains and also some Pseudomonas and Proteus strains as well. It is only used in prophylaxis. In acute setting, it is not helpful. But the evidence is mixed, probably because they all had small numbers. Most of the studies, different formulations were used in different studies, and the doses were different. And in a meta-analysis of 9 randomized trials, there was a decreased risk of UTI among 639 patients who used cranberry products compared to 536 control patients. And given that they're easily accessible, low adverse effect profile, and do not carry resistance as antibiotics, I think women with recurrent UTI should be informed of this mixed evidence and still be offered. So next we move on to probiotics. Probiotics are nothing but live microorganisms that are thought to confer health benefits on consumption. They are the predominant commensal organism in vaginal and periurethral areas, responsible for preventing adherence and migration of pathogens to the bladder urothelium. They also have antimicrobial effects against ESBL E. coli, as well as multi-drug resistant bacteria. There are several strains, and the largest effects are seen with the Lactobacillus plantarum and fermentum strains. They also have a role in modulating the host immune system, which are now the novel targets of future therapy. So how do these probiotics work? This lactobacilli prevent adhesion of this E. coli to the urothelial lining. They also form a congregation around the E. coli. They, they produce hydrogen peroxide and lactic acid, and the acidic environment prevents the formation of biofilm, and they also downregulate the inflammatory markers. So theoretically, it sounds very promising. So what is the evidence we have against that? So they showed mixed results, all the clinical trials, and that is because there was a large heterogeneity in strain. As I mentioned before, the Lactobacillus plantarum, they are more bactericidal and helpful. Different strains were used in different studies. The mode of delivery was different. The dosages, what they used was different in different studies, and the length of treatment also mattered. So and due to all these things, the trial showed mixed results. This is an interesting study which was done. It's a randomized double-blind non-inferiority trial in some postmenopausal women. They looked at people who were using Bactrim as prophylaxis and Lactobacilli as prophylaxis. As you see here, people who were on Lactobacillus prophylaxis had a lesser incidence of antimicrobial resistance, whereas on Bactrim prophylaxis, the resistance patterns for antibiotics was much higher. This looks kind of promising to put them on probiotics. So in 2015, a Cochrane review of all the randomized control trials concluded that vaginal probiotics provided no significant benefit over placebo. And so a meta-analysis done on oral probiotics were safe and effective in preventing recurrent UTI, but no definite recommendation can be made as of yet. So vaginal probiotics is a strict no, but oral probiotics, a recommendation cannot be made. I think use of well-characterized strains are warranted, and large trials are required before they could make any recommendation, but theoretically it sounds very promising. Next, D-mannose. D-mannose is a monosaccharide isomer of glucose. It's involved in glycosylation of certain proteins. The absorption is very rapid and when taken orally and excreted in the urinary tract. How it does is it prevents binding of bacteria to urothelial cells. So as you see here, D-mannose resembles this uroplakin receptors, and they competitively bind to the fimbrial attachment of the E. coli, and it prevents it from attaching to the urothelial cells. And by preventing adhesion is how it helps in preventing UTI. There's one randomized trial done where 308 people with recurrent UTI were randomized to D-mannose versus nitrofurantoin and placebo. At 6-month follow-up, D-mannose and nitrofurantoin had a statistically significant lower incidence of recurrent UTI compared to no prophylaxis. But there was not much difference between D-mannose versus nitrofurantoin. Both of them had the same effects. Compared to placebo, it was better. So it may reduce the risk of recurrence, but larger randomized studies are required to validate its use at this point. Methenamine hippurate. It's not much heard of over here, but it is predominantly done in UK. It's a cyclic hydrocarbon which is hydrolyzed to ammonia and formaldehyde. It is thought to be bacteriostatic in view of its formaldehyde production. In 2012 Cochrane review, 13 studies involving 2,000 participants were included. Results were not interpretable due to heterogeneity. but the subgroup analysis showed that it was beneficial. There is a large multi-center trial being done in UK at this point, and they have completed recruitment. It's ALTAR trial. The results are yet pending. Let's see what it shows. So estrogens. So estrogens are potent regulators of cell growth and differentiation. Expression of these receptors are seen in distal vagina, the trigonal bladder, and epithelial lining and submucosal vascular complex of urethra. Circulating estrogens increase vaginal colonization with lactobacilli, and postmenopausal declining levels contribute to the chemical and structural changes, and there is declining lactobacilli level as well, postmenopausal status, and that increases the risk of UTI. So what is the evidence against estrogens? Systemic administration, 4 randomized trials did not show any benefit. Adverse effects were very high, and it is not recommended for prevention of urinary tract infection at this point. What about local administration? Intravaginal creams, impregnated pessary rings, vaginal pessaries, vaginal tablets have been studied. 2 randomized trials looked at locally administered estrogen versus placebo, showed a significant reduction. 2 randomized trials comparing vaginal estrogens with prophylactic antibiotics showed a significant reduction in estrogen cream group. So topical creams are more effective than rings or pessaries based on the studies. So intravesical glycosaminoglycans. So what are these? The surface of the bladder urothelium is lined by mucus layer composed of glycosaminoglycans. This is a very important host defense mechanism, and loss of this layer is believed to be the initial step in chronic inflammatory bladder conditions. So there were some studies evaluating exogenous analogs of glycosaminoglycans. And look at these studies, about 5 to 6 studies have been done, and their mode of action is reduction of adhesion. Some promising results in humans were seen, only retrospective studies though, but it's too expensive because it involves intravesical installation. So at this point, it is not recommended. Moving on to immunostimulants and vaccines. Why is it so difficult to develop these vaccines and immunostimulants? There are certain limitations to that, like lack of natural protective immunity in humans after UTI, lack of induction of antibodies in the bladder, diversity of pathogens, and the desire to avoid inducing a pathological immune response to colonizing bacteria in the gut. These things make it very difficult to develop a suitable immunostimulant and vaccine. However, those that are studied in humans are these 3. Urovaxone, which is an oral capsule. It's against 18 serotypes of uropathogenic E. coli. Urovac has been studied as a vaginal pessary cream or suppository against 6 serotypes of uropathogenic E. coli, Proteus, and Klebsiella, and Uromune, which is a sublingual spray. They activate both the innate and adaptive immune system by activating dendritic cells, neutrophils, and T helper cells. Also causes activation of T and B lymphocytes followed by release of IgA resulting in immunoprotection. So this Urovaxone, the meta-analysis of 4 randomized control trials found to reduce UTI. It was effective only against E. coli though. The Urovac beneficial effect noted in 3 randomized phase 2 trials only. Euroimmune, excellent benefit in retrospective cohort series, but randomized placebo control trials are awaited yet. So what about the vaccines? Novel vaccine targets are against the Fimbriae, the exotoxins, the lipopolysaccharide surface, capsule, flagella, and iron receptors. These are all the targets that have been studied, but only in preclinical studies. As you see here, they were targeting adhesion, targeting the capsule, targeting toxins, and targeting iron metabolism. But still, there's a lot more studies to be done, and it can't be given yet. Hopefully, we will get them in future. So what does the European Association of Urology recommend regarding non-antimicrobial prophylaxis? The advice on behavioral modification to reduce UTI, it's a grade C recommendation. Vaginal estrogen replacement is a grade A, only in postmenopausal women with recurrent UTI. And immunoactive prophylaxis to reduce recurrent UTI. based on the studies of Urovaxone. It's a grade A recommendation. And probiotics, cranberry, D-mannose, intravesical installations, there is no recommendation yet. Further trials are warranted. And finally, I guess from what we have, we conclude that behavioral changes as applicable really helps. Cranberry and D-mannose, looking at the way it works, it can be considered because it has a very low adverse effect profile. And if the patients are willing to take, we can educate them and probably given. Probiotics seem promising. Estrogen definitely for postmenopausal women. And while we await for the immunostimulant trial results, hopefully there's something promising. Thank you.
We invite the chairpersons for their valuable opinion.
Hello, can you hear me?
Yes, sir.
Dr. Suma, it's an excellent talk. Excellent talk. So you have covered everything, almost non-antibiotic treatment. See, even I am using this one, Cranpac D. As you told, no, it is giving a mixed result.
Yeah.
Two things I want to know. One thing, what is there any out of our non-antibiotic therapy? What about your prophylactic and suppressive therapy? One thing. And the surveillance of urine testing in especially female, you have recurrent UTI episodes. And is there any other preventive strategies for men, especially men? These three things I want to have from you.
Yeah, see, this is a very debatable thing. See, the other things is the antibiotic prophylaxis. I did not even touch on this over here because that itself is a different topic to discuss. You know, and it's there is really no one yes or no answer here, and I think it is each one's individual experience when it comes to that. And surveillance cultures are always so difficult because you check the culture and it comes positive, then what? Are we going to treat them or not? It really depends whether they are symptomatic or asymptomatic. In fact, after this, I was going to tell you that I have a survey that I have listed out all these questions, which I wanted to look at the responses from each and every nephrologist and physicians who are treating as to how their practices are, because it's your own practice, how you're doing it and what you're comfortable with. So what I do is in diabetics, after you treat them for a certain period of time, and if they're asymptomatic, I do not repeat the culture because you don't know what to do after that, because giving antibiotics for a long time will lead to resistance. So definitely, if they're symptomatic, I'll repeat the culture and treat it as required.
Just one more thing is duration. See, I have been treating one patient.
Yeah.
See, I put her on Niftas, just niftapratan 50 milligram. As soon as stop the Niftas, after 2 weeks, she'll come with a symptomatic UTI. So I've been continuing since almost 1.5 years. She's a I think she's a wife of some metro. He works in metro, this one. See, before coming to me, she had a horrible situation. She was getting recurrent UTI with pyelonephritis. After I put the Niftas, almost 1.5 years, 2 years, as soon as I stopped the Niftas, she again recovered with a symptomatic UTI, that to pyelonephritis like that. So now, anyway, I put her on this one. So duration, even if Cranpac D also, we don't know the duration, how many days we have to give. And it's quite expensive to use, that's what. See, duration, I don't know.
See, these are the things that I actually try to look up, what is the thing, because nobody knows how long to give. Actually, even in the studies, they do not even mention that. And in somewhere they mention like 6 months, you can use this cranberry. And when it comes to antibiotic prophylaxis, you give for 3 months, stop it and see if they're symptomatic, continue for a year or 2. That's all. It's very vague. There are no answers to these questions at all.
And moreover, see, my suggestion is gynecologist evaluation has to be done in all recurrent UTI patients, especially women.
Yes.
Yeah.
Absolutely, absolutely. Yeah. Vaginal infection, actually, that is one of the most contributed to this, which I want to mention.
Vaginal candidosis is also more, I've seen more candidosis. As soon as treatment, they'll be relieved of all symptoms. Especially with atopic vaginitis and vaginal candidosis.
Yes.
Thank you. Thank you. Very good talk. Thank you.
Thank you.
So that was a very excellent and expansive discussion, Dr. Soma. Congratulations for that. One thing I agree with you is that even I do not tend to repeat the urine culture once they are asymptomatic. Many patients do it on their own, and I discourage that because once you have treated them and they are asymptomatic, repeating the urine culture in recurrent UTI often leads to a very positive culture, and then you're in a fix about what to do next, whether to treat or not to treat. Regarding the prophylaxis, you threw a lot of light on intravesical therapy and vaccines, which I believe are not yet recommended. So probably time will tell us. So we are still quite limited in terms of prevention. So the behavioral therapy, cranberry, and urology and gynecological examination, I think, and D-Manos, as you said, remains the mainstay of prophylaxis.
At this point, I would like to request everybody over here. I'm going to send you a link for a survey regarding, treatment patterns for UTI. If you can take some time and try to fill it, it'll help us to know how different people treat UTI, the duration, and what medications they use. Hopefully, it will throw some light on our practices and whether we can change it or so. I will just send it in the chat box, and it could be filled in at your convenience.
Yeah, we'll do that.
Yeah.
Congratulations, madam. It was a very good presentation. So what I would like to add on as a female physician is most of our patients do not even, they hesitate to, especially the female patients hesitate to complain about the urinary disturbances that they are facing. So especially when the physician is a male, they will not bring out their issues. And
Yes.
male physician may not be able to counsel the patients because 50% of the patients having recurrent UTI are females, as of what I've observed in an OPD practice. So they may not be able to counsel about what are the behavioral methods that can be employed. So more focus will be on curative management rather than the preventive strategies. So as an observation also, even in the diabetics, a urology evaluation most of the time doesn't happen because they do not complain of voiding disturbances. So that is what we may have to focus on, and as well as insist all the physicians to ask about the bladder disturbances and bowel disturbances. That routinely patients don't complain because they hesitate to complain, especially the rural population.
Yes, absolutely. Absolutely. I think very well said. Yes.
Dr. Soma Raju, there are a few questions in the chat box. One is about the efficacy of antibiotic bladder irrigation like colistin, gentamicin, and amphotericin. Bladder irrigation, does it work?
Sorry, just come again. I would. What
efficacy of antibiotics bladder irrigation like colistin, gentamicin, and amphotericin bladder irrigation, does it work? By Dr.
There is no data regarding that. And again, installation, there is, again, you have to follow aseptic precautions, whether we will introduce any infection over there, but there is no data regarding that. Whether
and the treatment duration of urinary tract infection by antibiotics?
It is very, very varied. It depends whether it's a complicated, uncomplicated thing. So I did not address it in this setting because that itself is a different talk. So for a simple UTI, 5 days is recommended. If it's a complicated one, 5 to 7. There are a lot of patient factors to be considered in that. What kind of, whether it's a multi-drug resistant bacteria or is it a first-time UTI? It really depends on that, the duration of treatment. There is no one right answer I can give to that.
Yeah, I think your questionnaire is exactly going to answer that.
Yeah, that is the whole idea, to put that questionnaire, because everybody, treats differently. I want to know, like, what is the majority, what they are doing, because you can't find those answers in, if you look at the literature.
And lately, sorry.
Yeah, yes, ma'am. Please go on.
No, I said lately the antibiotic resistance is only increasing, and we really have to resort to some measures. It's a very disturbing symptom to have, and we really have to resort to some non-antibiotic measures as well.
Yes. Yeah.
Thank you, Dr. Suma Raju, for that excellent presentation. I thank Dr. Sridhara CG, HOD, Department of Nephrology, Institute of Nephrology, Bangalore, Dr. Tapoti Mukherjee, Lead Consultant, Nephrology, Aster Whitefield, Bangalore, Dr. Pooja Prabhu, Assistant Professor, Nephrology, MS Ramaya Medical College, Bangalore, for sharing your valuable time and your valuable insights with us. Moving on to
Thank you, Maitri, for organizing this.
Thank you, ma'am.
Yeah, thank you, Maitri.
Thanks a lot, ma'am.
Moving on to the next session, it is Diet for Chronic Kidney Disease Patients by Dr. Christine George. She is a consultant nephrologist and renal transplant physician from Aster Whitefield, Bangalore. I invite the chairpersons, Dr. Mayuri Trivedi, Head Department of Nephrology, Lokmanya Tilak Municipal General Hospital, Bangalore. Dr. Mayuri, ma'am, are you here?
Hi, Maitri. Yeah, so it's not Bangalore, it's Mumbai.
Oh, sorry, Mumbai.
Yeah, not an issue.
Christine George, can you please share your screen?
Christine is muted.
Maitri, I think Christine is muted.
Yeah. Am I audible now?
Yes.
Yeah.
Are my slides visible to you?
Yes. Put it in slideshow mode and start.
Yeah. Good morning, everyone. Thank you, Maitri ma'am, for the introduction. Moving forward, now we would discuss about diet for chronic kidney disease patients.
Ma'am, sorry to interrupt you, but this PPT it is not in slideshow mode. So please.
Okay, sure. I'll just do it again.
Stop the sharing and please share again.
Yeah, I'll do it.
Share screening, ma'am. Share screen. Okay. Now click on slideshow mode, ma'am. That bottom.
Okay. I had opened another window. I'll just close this just a second. Okay. Just a second.
Christine, you can just click on the slides on the left panel. We can see the first slide. You can just click on the slide in the left panel.
Yeah. Is the slide moving?
No, it's not moving.
No, ma'am.
Okay. I'll just share it again.
And share your screen only. Then only we will be able to visible the screen.
Entire screen. Yeah, I'll share the entire screen. Is it slideshow mode now?
Yes, ma'am. Now it is on a slideshow mode.
Yeah, sorry for the delay. So quickly moving forward, next we are discussing a very important yet relatively less discussed topic, which is important for the management of chronic kidney disease patients, that is diet. We all have heard the saying that you are what you eat. And recently I came across this, which says the food you eat can be either the safest and most powerful form of medicine or the slowest form of poison. I think this is most adept in the setting of chronic kidney disease patients. So this is a question we very commonly come across in our day-to-day practice, asking us that the patient in front of us asks, "Doctor, please tell me at the end of the entire discussion, what can I eat and what not to eat?" What you eat is very important part of CKD management. The right diet can help prevent complications like high blood potassium, fluid overload, high blood phosphorus, and bone disease. And it can facilitate weight loss in an obese patient. And also, it helps to maintain the right weight. And very important is the right diet can make you feel much better. And we all know how important it is for our CKD patients. So now, what is the connection between food and the kidneys? Kidneys function to remove the waste material from the food you eat. And the kidneys excrete urea, potassium, and phosphorus, and these accumulate in kidney failure. If you regulate the content of these in your diet, the accumulation of these substances can be regulated. So what is the right diet for me? Depends on the stage and nature of your kidney disease and the type of treatment you're on. It is not a one size fit all kind of prescription or kind of advice we can give to every patient. Depends on the laboratory test that you're having. Presence of other medical conditions also influence the right diet for you. Now, in the coming 10 to 15 minutes, I'll try to discuss the important dietary components, how it is connected or how it gets altered in the dietary in chronic kidney disease, and how to manage each component. I'll try to make it simple for the non-medical audience. So starting with protein, because it is a very strongly ingrained idea that as soon as somebody has kidney disease, one should stop all the protein intake, or we should strictly restrict the protein intake. So protein is an important component of muscles and bones. Your hormones, enzymes, everything is made up of protein. It helps in muscle recovery after exercise and repair of normal wear and tear in the body. And it is very important for recovery from an acute illness. Excess protein in diet leads to increased pressure inside the glomeruli. Glomeruli are nothing but microscopic filters within the kidneys, and the excess protein in diet increases the pressure within the glomeruli. In non-dialysis CKD, it is advised that protein restriction should be followed. That is a restriction to less than 0.8 gram per kg per day. This is to reduce the glomerular hypertension, and it has been shown to slow down the disease progression. But at the same time, a patient who is in early stages of CKD with nephrotic range proteinuria, somebody who's losing, let us say, 10, 12 gram of protein in urine, should be able to replenish the protein loss in the diet in addition to the 0.8 gram per kg intake that is advisable. This is again important, because if we say protein restriction, suddenly the patients who come to us mostly are already on vegetarian diet. They cut down on the already deficient intake, and they can be pushed into malnutrition. What about those patients who are on dialysis? So dialysis patients need to take around 1 to 1.2 gram per kg of protein, those who are on hemodialysis. And on peritoneal dialysis, this is higher, that is 1.5 gram per kg. This is to account for the losses of protein during the procedure of peritoneal and hemodialysis. And also the patients on dialysis are in a catabolic state. And unlike in early stages of CKD, the diet, once you're in dialysis, should include more proteins. And this is again very important, because many patients continue the dietary restrictions imposed on them during the pre-dialysis or early stages of CKD once they start on dialysis as well, and it can lead to malnutrition. So some of the protein sources, the rich protein sources are, of course, the animal sources, that is egg, the egg white, chicken, fish, and your dairy sources all are rich in protein. And there are enough sources of, or enough options for the vegetarian diet as well. And if one can include the dairy products, especially the paneer, the cheese into the vegetarian diet, they are good sources. And also the pulses, the larger, the chickpeas, rajma, these are good sources of protein. So that is about protein. Next, coming to calories. Calories are nothing but energy blocks in the diet. And for a average sedentary worker, about 30 to 35 kilocalorie per kg per day is the energy requirement. And again, our patients who are on dialysis are especially in a catabolic state. and they require calorie-rich diet to ensure the protein utilization. So again, once the patient is on dialysis and on optimal dialysis, adequate intake of calorie-rich diet should be stressed upon. And if a patient is diabetic, of course, we have to tailor-make the dietary prescription to include a low glycemic index sources of calorie. Next, coming to sodium. Sodium, again, an essential element which directly regulates the water content in human body. So kidneys, as we all know, play an important role in maintaining homeostasis, the correct level of balance with respect to the electrolytes, minerals, and water. So excess sodium in diet is excreted in urine by the normal functioning kidney. But in chronic kidney disease, the sodium accumulates in the body, resulting in excessive thirst, fluid overload, poorly controlled hypertension. So the sodium restriction itself can help in fluid management. That is a very important aspect, because we want to delay dialysis in our chronic kidney disease patients as much as possible. And many times fluid overload becomes an indication. So if a patient is able to restrict the salt to a large extent, we'll be able to manage the water excess. And also on dialysis, while the patient is on dialysis as well, we will be able to manage the fluid gains between dialysis sessions by managing the salt intake. So now, how much salt should I eat? Daily sodium intake advised is less than 2 grams. So this means a salt, that is a common salt of less than 5 grams per day. So how to measure it? 1 teaspoon, what we commonly use, a level teaspoon contains about 5.5 grams salt. So it is just 1 level teaspoon. If you take, that will come little more than 5 grams. And this is the 24-hour quota of salt that is allowed. So again, it is very important to measure the amount of salt that goes into cooking. Many times we say during our consultations that we have to restrict the salt in the diet, and the patient says that I have reduced the salt, I have stopped taking salt rich. But then the average Indian diet itself contains about 8 to 10 grams of salt. And when we say salt restriction, unless the patient counts the salt, it is practically, probably he's still taking 6 to 8 grams of salt. So always it is better if the patient can have a home cooked food without salt, add salt on top in that measured quantity, that is 5 grams for the entire day. And the sodium rich food to be avoided would be the cheese, snacks, the achar, the salted pickles, chips, the processed food, the canned food, everything is rich in sodium. So an alternate to salt would be herbs and spices, which can be added. And but again, the salt substitutes should not be used, especially in CKD patients, in diabetic CKD who are prone for hyperkalemia. Salt substitutes should be avoided, and use home cooked food as far as possible. Next important mineral is phosphorus. It is important for bone health. A normal diet contains phosphorus in excess of the body's requirement, which is easily excreted by the healthy kidneys. So as the kidney function declines, phosphorus gets accumulated. It can cause muscle aches and pains. Hyperphosphatemia can predispose to brittle bones, and also can lead to calcification of the heart and blood vessels. So how to control? Again, initially we discussed about the importance of high protein diet. So with high protein, usually the phosphorus also comes into play. So the meats, poultry, fish are all rich in phosphorus. Milk and milk products are also rich in phosphorus. All the red beans, rajma, black beans, fruits, dry fruits. So again, if a patient is having issues with high phosphorus, we have to strike a balance with adequate dosages of phosphate binder. So protein intake is important. Simultaneously, we have to manage the phosphorus intake by adequate dosage of phosphate binder. Next, coming to potassium. Potassium again is a predominantly intracellular mineral. Potassium is an important element required for functioning of the heart, nerves, and muscles. And any fluctuations in the blood levels can affect the functioning of the heart and the nerves. It again comes from the common food items that we normally eat. Healthy kidneys remove the excess potassium in the urine to help maintain the normal levels in the blood. Diseased kidneys cannot excrete the excess potassium in urine, and high potassium can cause rhythm disturbances in the heart or even stop the heart up very high. And what are the high potassium food that one should avoid if advised to restrict on the potassium? Mainly the fruit and vegetables. The fruits, the high potassium fruits are bananas, the citrus fruits are rich sources of potassium, and any concentrated, that is, if you take fruit juices, these are high potassium. The tender coconut water is high potassium content, and the green leafy vegetables. And in fact, most of the vegetables have potassium. The green leafy ones have more. Potatoes are rich in potassium. The yams and sweet potatoes are rich in potassium. So what is the way to remove the excess potassium or reduce the potassium content in the fruits and vegetables? One can remove some amount of potassium by the process of leaching. So leaching basically means that you put the vegetable or the green leaves which are prior to cooking, soaking in water for about 1 to 2 hours, boil it, discard the water, and subsequently cook and eat. This removes potassium to a large extent. Coming to next important component of diet, that is fluid. So fluid restriction is an important aspect of managing chronic kidney disease, be it pre-dialysis or the dialysis state. Restricting salt helps us to control the fluid to a large extent, as salt pulls water. And it is very important to count the fluid in your daily diet. So unless the fluid is accounted for, it is counted, it is never, neither the patient knows how much he's taking nor the doctor knows. So when we advise fluid restriction, the patient comes back and saying that I am only taking small sips of water. But small sips 3 to 4 times, 5 times builds up, and it contributes to fluid overload. This is seen especially in our dialysis population, but even in the later stages of non-dialysis CKD. So fluid restriction would mean that everything that is liquid at room temperature is counted as fluid. It's not just water. So the tea, coffee, the rasam, the buttermilk, everything is counted as fluid. So that is about, I try to give an overview about the important components and how the modification is required in chronic kidney disease. Now, I would like to mention regarding malnutrition and how to prevent malnutrition with diet. The dietary nutrients are inadequate or inappropriate to meet body needs is a situation which we call as malnutrition. And malnutrition and frailty directly contribute to increased risk of mortality in chronic kidney disease patients. And multiple studies have proved this beyond doubt. And an important contributor to malnutrition is a continued dietary restrictions, especially protein, in dialysis patients. And the malnutrition predisposes these patients to increased infections, poor wound healing, fatigue, and depression. And this leads them into a vicious cycle. So naturally, patient does not have good taste, they are fatigued, they don't feel like eating. And this goes on. And once they start on dialysis, they don't do well, they get readmitted with infections, the fistula wound doesn't heal. So malnutrition is an important and how do I put it, often a problem which is very difficult to tackle, especially in the Indian scenario, wherein patients are already protein deficient. And then we advise protein restriction, they come to dialysis stage wherein they are malnourished. So it's important to have a patient tailored dietary advice, include dietitians in early stages of CKD itself, give patient tailored dietary charts, and follow up with modifications as required. So this is an example of how a dialysis plate, that is a patient on dialysis, the food plate, how it should look like. Half of the plate should be high quality protein. So it can be meat, poultry, the egg, lentils, fish, tofu, paneer, all these contribute high quality protein, and half of the plate should be high quality protein. And of course, the 1/4 is the calorie source, that is grains and the bread, and the other 1/4 is fruits and vegetables. So this is how a plate for a dialysis patient should look like. To conclude, diet is a very crucial aspect of management of kidney disease. It can prevent delay progression of kidney disease. It can improve quality of life. Patient-tailored diet plan at each stage of disease is mandatory. And an early dietitian referral and discussion on diet during routine consultations. Starting from early stages of CKD, a discussion about the diet during our routine consultation can go a long way in patient management and better patient outcome. There are good resources on the diet for the patient and caregiver. The National Kidney Foundation is one I found. They have diet plans and diet charts which they have given. Thank you.
Thank you, Dr. Christine George. I invite the chairperson, Dr. Mayuri Trivedi, to share her views on the topic.
A beautiful talk, Christine. I thoroughly agree with the 2 or 3 points that you have made. Is that one is in that our zeal to kind of restrict protein, we need to keep in mind that a lot of our patients, the majority of our patients may have underlying malnourishment as a problem. So we need to be careful that, in order, the balance is what needs to be achieved. And rather than kind of restrict, because the myth is always that if you have a kidney disease, you have to stop protein. So I'm sure all of us have patients who come to our clinic saying that we have stopped taking protein, we've stopped taking dal, we have stopped taking milk products. But the message that needs to go across is it would be wiser probably to just shift over to a vegetarian diet as compared to animal protein, because we have enough studies now which say that the vegetarian protein may be a better bet in patients of CKD. So these are patients who are not on dialysis as of now, and for the progression of the CKD. And should the patient be already dialysis dependent or is in ESRD, at that point of time, as you rightly said, that you have to have a well balanced meal with half of the plate having a first class proteins and enough serving of fruit and vegetables and all of it. The second point that you very rightly made is, again, just in order to control the phosphorus, we should not be restricting the proteins very majorly, because we have the choice of a variety of phosphate binders where cost is probably not an issue anymore, where we can use that and titrate that and look after the CKD MBD part of the disease, but let the patient have food and not go on to malnourishment, and obviously the quality of life.
Dr. Christine and Dr. Mayuri, there are a few questions in the chat box. I think both of you can answer it. Protein intake in relation to proteinuria levels. What is your comment?
Christine, you want to take that?
Yeah.
I think you already
Yes,
mentioned
ma'am.
it. Yeah.
Yeah, so in patients with large amount of protein loss in urine, always the losses should be replenished. And when we restrict protein in early stages of CKD, non-dialysis population, to 0.8 gram, in addition to that, we should account for the protein losses in urine. So I didn't see the question. I think that is what the question is about, ma'am. Mayuri, ma'am?
Yeah, I absolutely. So what Christine has rightly said is that if there is a patient who's proteinuric, that is loss of proteins, make sure that is quantified, and that protein which is lost in the urine should be replaced by first class proteins. And then depending on what your baseline disease is, if you're a CKD, you need 0.8 grams per kg per day. If you are somebody who is having a nephrotic syndrome, you would have a little more than that. We can give up to 1 gram to 1.2 gram depending on what your serum albumins are. So the loss in the urine has definitely to be replenished in the diet apart from what your restrictions are.
Ma'am, also we have a transplant patient who has joined us. He says, I'm a post-kidney transplant, 4.5 years old, and how to control protein loss.
So that this would be something, sir or madam, I'm sorry, I don't know, but this would be something that your doctor would be able to tell you with various medicines. So we have this whole, barrage of drugs that are right now there. So apart from diet, these drugs can be offered to you. But again, reiterating the fact that just to control the protein in your diet, please don't go on any drastic, diet measures or restrictions in your food without your doctor's knowledge.
We have another question from Venkatesh Natarajan. He says, given the fact that most Indians are protein energy malnourished, is there a need to reconsider protein restriction guidelines specific for the Indian population of CKD?
So I guess that's what Christine and I were trying to
correct.
make a point already, that just don't be over enthusiastic. The myth about protein restriction, especially in our country, needs to be readdressed case-wise.
In the era of RAS blockade and SGLT2 inhibitors, should we reconsider protein restriction guidelines? Can protein restriction alone have benefits more than these drugs in reducing hyperfiltration? Again, by Venkatesh Natarajan.
So again, I think my reply to that would be that, dietary protein restriction is a part of the armamentarium for, controlling the CKD progression for sure. Whether by itself would it be as effective, I am not too sure. Maitri, maybe if you are aware of any head-on trials where they have done only dietary restriction with these drugs. But again, it's the same point that we are going in circles, that just because you do not want to take drugs, restricting your proteins to an extent that you tend to fall over on the malnourished side. I think it's a silly thing to do. I would rather take the drug but make sure that my patient eats well. I don't know, Christine, your take on that.
Yes, ma'am, I absolutely agree with you. So this is very strongly ingrained in our patients, I believe, that you stop all the protein and the kidneys are going to function well, and you can come off medications, and then many times they don't even get tested. They don't come for follow-ups. They don't get their creatinine checked. We have seen patients. They say that, no, I have controlled all the protein source in my diet, and so I didn't get myself checked again because I thought that would take care of the kidneys. So I think there's a need for a lot of creating awareness among the patients, their caregivers, and the general public that there are multiple pathways which are involved in CKD progression. And proteins, yes, they lead to hyperfiltration, and hyperfiltration itself we are trying to target with our drugs. So it all goes hand in hand, and we have to prevent malnutrition, especially in the Indian setting, wherein already the protein intake probably is just marginal.
Absolutely. Protein intake is definitely low in Indian population. Last question is, plant-based proteins predominantly come from nuts, which are both expensive and with additional burden of potassium. What role does protein supplements play to make up for malnutrition? Again, by Dr. Venkatesh Natarajan.
Yeah, so protein supplements, I'm sure, are costlier than the nuts, sir. So regarding the cost factor, yes, it is costly to include a high quality plant-based protein in the diet, because our dal and lentils, they have lesser concentration, and the quality of protein and absorption of protein compared to the animal sources of, for example, the egg white, is suboptimal. But again, there are now soya protein, and the concentrates of soya protein is available, or the lentils or the rajma, the chana, all these are good sources of protein which can be included. The dairy products, of course, paneer is a very good source, which is not that costly.
Thank you so much, Dr. Christine, for enlightening us on diet in chronic kidney disease patients. Thank you, Dr. Mayuri ma'am, for sharing your valuable thoughts, insights, and answering the Q&As and sharing your valuable time with us. Moving on to the next session, Dr. Aditya Shetty.
The next talk would be on exercise for CKD patients by Dr. Kritika Mohan. The chairperson will be Mr. Sumir Kumar, Managing Partner, Fireflies Entertainment, Volunteer KWF, and Dr. Indu Rao, Associate Professor, KMC Manipal. Before we proceed, a brief introduction to Mr. Sumir Kumar. Mr. Sumir Kumar Padmanabhan is a kidney transplant recipient. He is a former professional cricketer. Life was good for Mr. Sumir in the early 2000s. He was a rising star in the cricket field with the goal to play for the country. However, an incident of extreme dehydration led to an acute kidney injury. Fortunately, due to timely intervention, he was able to recover and played for almost 4 more years when unfortunate circumstances cut short his cricketing career. He moved away from cricket into learning the science of sports and exercise and became a well sought after wellness consultant. 12 years later, a severe bout of bronchitis and chest infection while on a high altitude training program caused both his kidneys to shut down. He was advised dialysis, and after waiting for 3 years, he received a kidney from a cadaver donor. This kidney also failed 3 years later, pushing him back to dialysis. While he was in the documentation process for his second transplant, he was rushed for an emergency surgery due to aortic dissection. March 2019 began with a series of hospital stays with a count of 8 critical surgeries till September 2019. When he was fit enough to undergo a second transplantation with a close family friend as a kidney donor. To feel the thrill of life after transplant, within 3 months, he got back to his physical fitness training to participate in a 10-kilometer run. He was overjoyed to have reached the finish line, and as a result, he is now in the Asian Book of Records as well as the Indian Book of Records for being the only 2-time kidney transplant recipient who ran a 10K within 100 days of his transplant. But fate wasn't finished with Sumir, and in 2020, he had a repeat aortic dissection as well as cataract surgeries in both his eyes. Through all of this, Sumir has not given up on his dream to play for his country. He is currently training to participate in the upcoming 2023 World Transplant Games in Perth, and he will be competing in multiple sporting events like badminton, football, and tennis. He firmly believes that even with multiple serious health conditions, life can be lived with full of gusto. Welcome, Mr. Sumir Kumar, to the panel. I request Dr. Indu Rao to introduce Dr. Kritika Mohan to give the talk.
Dr. Aditya, can you please share the series slide? Hello, am I audible?
Yes.
Aditya, can you share the CV slide?
Which slide, ma'am?
Slide of Kritika. Kritika, do you have a CV slide?
No.
Oh, okay. Okay, all right. So first of all, I would like to thank the organizers for inviting me to be a part of this seminar today. And it gives me great pleasure to introduce the next speaker, Dr. Kritika Mohan. She is a consultant nephrologist and transplant physician at Trustwell Hospitals, Bangalore. And she's going to be talking to us today about exercise for chronic kidney disease patients, which is a very important but often neglected topic. Over to you, Dr. Kritika.
Hello, everyone. Thank you, Dr. Indu, for the introduction. I'm just trying to share my screen. I think Kristen is still sharing hers.
Christine, can you please stop screen share?
Yeah, sure. Is it visible?
Yes, please go ahead. Put it in slideshow mode. Yeah.
Okay. Hello, everybody. Today I will be talking about exercise for people with CKD. So in my talk, I'll be covering physical inactivity and CKD. What are the benefits of exercising? What are the recommended types of exercises? What the guidelines say, and how can we improve? So firstly, what is sedentary lifestyle? It's a lifestyle where there is little or no physical activity in which the person is sitting or lying down while engaged in an activity for most of the day. So the most common cause of the sedentary lifestyle is rapid urbanization and dependence on technology. And now post-COVID, the work from home culture. So this was a study done by O'Hare et al. It included 2,200 patients from the US RDS data. So here they tried to compare, they tried to see how many patients on CKD were physically active. So you can see that almost 35% of the patients almost never exercised, while only about 25% of the patients exercised more than 3 times a week. So in another study, which was done by Johansson et al., they compared the physical activity of patients on dialysis to sedentary control subjects, and the difference was statistically significant. So why is there lack of exercise in patients with CKD? So there are multiple factors which could affect the general well-being of a patient who has kidney disease. So one being that they have dietary restrictions, so they have dietary deficiency, their total energy expenditure is lower, which leads to malnutrition. This in turn causes weight loss and loss of muscle. So the biological age of a patient with kidney disease is greater than the chronological age, which again causes loss of muscle mass. CKD itself causes uremia, acidosis, and inflammation, which causes decreased absorption of nutrients, chronic inflammatory state, again leading to loss of muscle mass. Patients on dialysis have resistance to anabolic hormones. They have a lot of hormonal changes. They have amino acid loss. Patients who have kidney problems have more hospitalizations to those without. So all of these causes loss of muscle mass, which directly causes decrease in muscle strength. So this decreases the physical performance of the patient, decrease the ability to walk, imbalances while walking or standing, decreases their exercise capacity. So apart from that, they also have exercise intolerance. So patients with CKD usually have other comorbid conditions which contribute to this exercise intolerance. So we just spoke about skeletal muscle, there is sarcopenia, there may be underlying myopathies, which causes decrease in muscle mass and muscle function. They may have underlying fluid pulmonary conditions such as obstructive disorders, restrictive disorders. Fluid overload states in CKD can cause pulmonary dysfunction. Most of our patients on dialysis have increased sympathetic activity. They have autonomic dysfunction, causing imbalances and difficulty to walk and conduct their daily routine activities. They also have underlying cardiac disorders. Most of them have diastolic dysfunctions. Some of them have systolic dysfunctions. They have myocardial stunning every time a patient undergoes dialysis. And also abnormal vasculature because of endothelial dysfunction, impaired sympatholysis, arterial wall stiffness, which we see. So all of these directly contributes to exercise intolerance in patients with CKD. So what are the barriers to exercising in our patients? So mostly that they're generally sick, they're in and out of the hospital because of kidney disease itself or other comorbidities, increased risk to infection, maybe vascular access. So all of those, they complain of fatigue. They don't have the right equipment to work out. They are not motivated enough to exercise. And also because of depression. So what are the effects of physical inactivity? So it leads to poor physical well-being. There is a loss of muscle mass. There is loss of bone strength. They have poor appetite, poor control of diabetes, hypertension, fatigue, frailty, and they're dependent on their caregivers for their day-to-day activities. So this was a study conducted by Johansson et al. In 2007, where they tried to compare the lifestyle of patients on dialysis. So they compared those with sedentary lifestyle and those with non-sedentary, and they showed that the mortality was higher in patients with a sedentary lifestyle. So what are the benefits of exercise? The physiological benefits of exercise are there is decreased cardiovascular mortality, there is better control of hypertension, diabetes, lipid profile, there is a decrease in inflammatory markers, there is better absorption of nutrients, increased exercise capacity, and improved clearance during dialysis. The psychological benefits include reduced fatigue. They have a general improved perception of physical functioning. They have decreased anxiety, decreased depression. They have an increased vitality. And overall, they have an improvement in mental health. The functional benefits include they have improved muscle mass, especially with the strength exercises apart from cardiovascular. They have an increased 6-minute walk. They have reduced risk of falls in older patients especially, and they're independent of their caregivers for their day-to-day activities. So what are the types of exercises recommended for patients with kidney disease? So they can be of different types. The most important being intradialytic exercise. So these are essentially the exercises which are done during dialysis. They have a better adherence rate compared to the interdialytic programs, but they're inferior when it comes to cardiovascular pulmonary adaptations. Interdialytic, these are exercises which are carried out between dialysis sessions. They have the greatest gain of VO2 max, which is a measure of physical tolerance. And they also but they have a higher dropout rate. Resistance training, these are used to improve muscle strength. They're often combined with flexibility exercises and core stability exercises. They focus on each group of muscle and to strengthen them. Aerobic exercises are your walking, cycling, swimming, etc. They are cardiopulmonary exercises which improve the aerobic threshold and maximal oxygen usage. So these are some of the intradialytic exercises that can be done. They're very simple exercises. One being leg raise. This can be done in both sitting as well as lying down position. It can be easily done in patients undergoing dialysis. The other thing is the seated marching, where the patient marches. The other exercise which could be easily done is arm curls. This can be done with or without weights. And lastly, the toe tap. Toe tap again can be done while sitting as well as lying down. So these are fairly easy exercises that can be done during dialysis. These are exercises which require essentially equipments. So one is a cycle, the other is a stepper, and then weights. These add benefit to the other exercises. See, the advantages of intradialytic exercises: they reduce the post-dialysis rebound of urea, creatinine, and potassium. They remove phosphate. They increase the blood perfusion to various organs, especially muscle. They enhance the dialysis adequacy. They decrease muscle wasting. They decrease the protein loss during dialysis, and they improve growth hormone levels in patients. So this was a study done in 2021 by Graham Brown. So they tried to see if exercise during dialysis has cardiovascular benefits. It was done in 3 dialysis centers in UK. It was a prospective study. It included 130 patients on dialysis. So here they compared 2 groups. One group was the one which was getting standard care, and the other which included intradialytic cycling in addition to standard care. So these patients were followed up for 6 months. So at the end of 6 months, there was a significant decrease in LV mass in the intradialytic cycling group, and there was no increase in arrhythmias or ventricular ectopics. So they concluded that the 6-month program of intradialytic cycling reduces left ventricular mass. It is safe, deliverable, and tolerable in patients on dialysis. So what are the limitations of these exercises? So these are difficult to be done in patients who have low exercise capacity, who have extensive muscle wasting, who have disabilities, and who are basically dependent on caregivers for their day-to-day activities. And they don't usually undergo exercise assessment and adequate counseling. And there is very limited time in the 4 hours available for exercise counseling. And importantly, as healthcare workers, we lack training in exercise prescription, and the patient as well as the health caregivers, they fear adverse events related to exercise in the dialysis population. Adherence is better in intradialytic exercise. So it's best when it's done in the 2nd or 3rd hour during dialysis, or a day after the dialysis session. On non-dialysis days, there is lower adherence because they are not motivated, they may not have time, and other logistic issues. Second one is the aerobic exercise training. So it is recommended initially to start a moderate training process, which is progressed to vigorous exercise training. Initially to start with 30 minutes or more, 3 times a week. There are several options for home-based training, such as strengthening exercises, flexibility exercises, which can be added to these aerobic exercises, such as walking, cycling, swimming, and it should be gradually increased to about 3 to 4 times per week, and increased to more than and maintained more than 3 times a week. So resistance exercise. These are basically muscle strengthening exercises, which are an important determinant of physical performance. They're a predictor of gait speed in patients on dialysis. So some of the exercises are these TheraBand exercises, weight machine exercises, resistant band exercises, and weights. So combined resistant and aerobic exercises have shown to increase exercise capacity, decrease muscle atrophy, and improve autonomic control and decrease risk of arrhythmias in patients on dialysis. So the benefits of combined training can be seen in the study. This was a study done in Leicester. So they included, it was a small population of 41 patients who were not on dialysis, and they were randomized to either only aerobic exercises or a combined group with aerobic and strengthening exercises. So it was seen that the combined group had better leg strength, they were walking longer distances, and they had a better increase in muscle size. So they concluded that in non-dialysis CKD patients, aerobic exercise can increase strength, fitness, and muscle size. These are the effects of different types of exercises. Again, this is just to summarize that combined training, that is aerobic and strength exercises, increase the 5 sit-up to stand, 6-minute walk, increases muscle strength, it increases the metabolic parameters, decreases inflammatory markers, it decreases blood pressure, and it increases the general quality of life. So guidelines. So this UK Kidney Research Consortium clinical study group came out with guidelines. It included multiple professional groups of healthcare experts, and they came up with guidelines for patients with kidney disease who are not on dialysis, and had a transplant. So in patients with CKD not on dialysis, it is recommended, physical activity is recommended to those without contraindication and who have stable controlled comorbidities. These patients are recommended to participate in daily physical activity. They say that some physical activity is better than none. Maintain or improve their physical function by undertaking activities aimed at improving their muscle strength, balance, and flexibility at least 2 days a week. And aim to accumulate at least 150 minutes of moderate intensity aerobic activity, starting slowly and building up gradually. And break prolonged periods of sedentary activity with light activity, such as simply standing or a small walk. So what are the points for implementation of these exercises? So one should first be aware of the local exercise prescription policies. You should be associated with localized physical activity referral programs, have regular conversation about exercise with patients to raise their awareness. Physical activity could comprise of just general work or leisure time physical activities, structured activities, or sport. When possible, it should be supervised for compliance and efficacy. In patients on hemodialysis, again, physical activity is recommended for the population who have no contraindication. Aim for at least 150 minutes of moderate intensity physical activity and can then move on to 75 minutes of vigorous activity or a mix of both. Like I spoke earlier, this could be either intradialytic or interdialytic. This was another guideline that came out, Renal Association Clinical Practice Guideline on Hemodialysis. They also have similar guidelines for exercise, except that they emphasized on supervision for greater compliance and efficacy. So that essentially means intradialytic exercise. They recommend not exercising during the first 30 minutes of dialysis. And there is no evidence that light upper body resistant exercise has adverse effects on vascular access. I think most of the patients and doctor fear this. And importantly, individualize the exercise routine for each patient based on their general condition, well-being, and comorbids. So avoid exercise if they're only on dialysis for less than 3 months, when they have perceived physical and psychological barriers, and when they have unstable medical conditions such as angina, heart failure, arrhythmias, cardiomyopathies, when the BP, systolic BP is more than 200 and resting diastolic is more than 110, or they have had symptomatic hypertension or hypotension. So in patients on PD, they did not come out with guidelines, but this was a study that was done by Bennett et al., which was published in Kidney Medicine in 2020, is an exercise program feasible for PD patients in the USA. So this was a single center study. It included 75 patients on peritoneal dialysis who were on dialysis for more than 6 weeks and were ambulatory. So the intervention was resistance-based exercise and standard of care. They were randomized. So here they concluded that at the end of the study, 72% were retained in it and 76% adhered to the exercise program. There were no serious adverse effects, and they had in 77% of the patients had sustained exercise. So they concluded that resistance and cardiovascular exercise program, which is supervised, is feasible and safe for PD patients. So in transplant patients, so general physical activity should not be encouraged in patients with contraindications. So 150 minutes of moderate to vigorous physical activity a week is recommended. So in transplant patients, we should also identify individual barriers and activators to physical activity to optimize the patient uptake and adherence. We should give them a structured exercise program to enhance their cardiorespiratory fitness, muscular and physical function. Exercise should be performed at least 3 times a week if they have no contraindication. And again, it is recommended to combine both aerobic and resistant exercise to maximize the effect. And ultimately, each exercise program has to be individualized based on the patient's goal, expectations, pathophysiology, graft function, etc. So this is one of the protocol that was designed by Oguchi et al., which was published in 2018 for transplant patients. So this was a supervised, they had 2 protocols. One was a supervised aerobic training, which included exercise 5 days a week, 1 to 2 sessions per day and 35 to 45 minutes per session, which included either cycling or treadmill walking in the first week, and then continued on to the second and third week, and then at home. And physical activity instruction was during exercise, they had to use a pedometer. They had to do at least 3,000 steps a day and increase to 5,000 steps gradually. And at the end of third week, recommended to start climbing stairs. So the barriers in exercising in patients on CKD. So I think the most important barrier would be their health. So most of the patients have fatigue, other underlying comorbidities, fear of symptoms with exercise, and others being work. They don't have enough time when they're working, or they have family obligations. Environment, weather could be a problem for them to go out and work out. Safety issues, the cost of health, going to a gym or working out. And also they do not have social support from family or friends, usually because they're concerned that it may worsen their existing health. So how can we improve this? So motivating them, there are several ways to motivate them. First is to show them that exercise improves the overall health. With weight loss, there is improvement in blood pressure, there is lower risk to heart disease. So they show them that the quality of life is better with exercise. They have more energy and less stress. And basically support them while participating in exercise, maybe join them for a group session, and hold them accountable when they come to see you on an outpatient or when they come for their dialysis sessions. So this was a study done in 2021 by Anand S. This was done to see if physical activity could be improved in patients with CKD. This was again a randomized controlled trial, which included 56 patients with an eGFR less than 45 and had a 16-week follow-up. So here they were divided into 2 groups, one being a mobile health group, where they were wearing a activity tracker and there was a fitness professional counseling, and the other one being an exercises medicine group where they had directed sessions twice a week. So we can see that with supervision, both an active intervention and passive follow-up, that an integrated program is possible in improving the physical activity in patients with high comorbidities, and it is safe and feasible. So where there are various support groups available, such as the Global Renal Exercise Group, which has a lot of resources where you can read, where the patients can read about exercise in CKD. They do have some live programs or recorded sessions where they can join in. They also have group sessions for patients to join in and motivate them and hold them accountable. There's another support group called as BEAM. So this also has patient support group, which helps people with kidney disease with education and exercise programs and patient stories for their support and well-being. So again, what's the best inspiration again is real lifestyle life stories from our patients who have had transplants, who are on dialysis, both peritoneal hemodialysis, who are donors and recipients participating in such competitions. This is a picture from the World Transplant Games. So you can see our chair, Sumir Padmanabhan here. So I think this is the best inspiration. So I'd like to end my talk by saying if exercise were a pill, it would be one of the most widely prescribed and cost-effective drugs ever invented. Thank you.
Thank you, Dr. Kritika, for that talk. I would request the chairpersons, Mr. Samir Kumar and Dr. Indu Rao, to add their valuable opinion.
Dr. Kritika, thank you for that excellent talk. So I would really like to congratulate the organizers and for you for highlighting this very important topic. So, the quote at the end, absolutely nailed, the point which you were trying to make, right? So we nephrologists, in fact, most physicians and sometimes even patients are most comfortable with medications really, and other things which are equally important like diet and lifestyle modifications are sometimes, neglected and they take a back seat sometimes. So I think this is a very pertinent and important talk. So, thank you to the organizers and for you for highlighting this. I just have a few questions for you. One is that I'm sure a lot of patients would want to know if there are any particular types of exercises which they should not be doing. Are there any particular precautions that certain subset of patients would need to take before they start an exercise program? And are there really any termination criteria? What I mean by that is, something which would raise a red flag saying, you need to stop this exercise program. So could you just throw some light on these points?
Ma'am, like you said, so some of the patients who are not recommended to exercise would be, like I said, patients who are on the initial days of dialysis, because we are still giving the dialysis prescription. They're still getting used to the whole procedure, a lot of metabolic changes. So that's something where we would avoid in the first few weeks of dialysis. Second thing is, again, transplant, the first 3 or 4 days of transplant, till we know the graft is functioning well and patient is improving. So that would be one. But otherwise, if all of their comorbids are well under control, they have no major cardiac issues, I would recommend everybody to do some sort of physical activity. I wouldn't hold them off. And what were the other questions, ma'am?
Yeah, I want to know whether there are certain kinds of exercises which certain patients should not be doing. And are there any, red flags that, really indicate to the patient that, he needs to stop that exercise program or that it's not working for him?
So I think those red flags would again be like patients who have underlying cardiac disease, maybe an arrhythmia, sudden hypotension, or generally if the patient is not well, feeling ill, or if they've had a recent infection in the last 2 weeks. Those would be some of the things I would hold off till they get better.
Thank you so much, Dr. Kritika. And again, to Mr. Samir Kumar, I would like to say, sir, you are a true inspiration. Your story, I think, should really motivate all patients with CKD to really start exercising. And, it's really a lesson that CKD, a diagnosis of CKD should not really hold you back.
Absolutely. I think Dr. Kritika has covered almost everything. from the CKD before pre-dialysis, during dialysis, and also transplant. I think this, and the most beautiful thing is he's explained with a lot of studies, which not many people are aware of. Because this I have encountered in my personal life, and we speak to other nephrologists, the lack of awareness among doctors is also there. I come from a history of also being an exercise professional. So it's very important, as doctor said, exercise prescription to each individual is very important. As one of the questions where when do I stop, when do I do what kind of activities do, is all based on exercise prescription and with the consultation of the doctor. Here the doctor is going to be the nephrologist. Everything you do, you get an idea of how much you're doing, and you're the best judge for the whole activity. You know more than the doctor, it is the individual, and to some extent the exercise prescriptionist will know how much you can do and how much you cannot do. And the most important advantage of doing exercise apart from the physical thing is the mental aspect. And here people don't discuss about it because people who go through this CKD is going through a lot of psychological problems too. I think this doing a basic exercise will actually help them to look at their disease in a very different aspect. They'll start living life. And to me personally, being a sports person and not giving up during my playing days has helped me. Every time I went through my crisis, whether once during my aortic dissections or my post-transplant, for me, getting back and being healthy was my primary focus, and I want to be fit as long as I live. So I think that's the most important thing where exercise is going to help. And I think Dr. Kritika has covered the most important aspect of anybody who wants to understand if they can exercise or not. Thank you, Doc, for this beautiful talk.
Thank you. Mr. Sumir, I have a question for you.
Yes,
so as a part of Kidney Warrior Foundation, how do you motivate your members to take up an exercise program? And, I know you're a living example, but what do you do? I mean, when you have patients who are depressed or not motivated enough, how do you go about doing that? Do you have a support group? Do they talk to you?
I'm part of the organization called Kidney Warrior Foundation. Basically, it's a patient advocacy group. We try to help the patients, and the group is full of patients, and we have doctors, we have caregivers, and the support comes from all aspects. It's not just one person who is handling the thing. That's one thing. Second thing is we do a lot of talks, and we go to schools, colleges, and just some of the things we do. Currently, I'm doing along with my wife is going to school and talking about prevention and modification lifestyle, and about organ donation. These are a couple of things we talk about, and very important aspect I talk about is living healthy and talking about exercise, physical activity. In schools, we are trying to promote that in schools and colleges. And regarding patients, I think like we talk about here, it has to be individualistic. I don't want to say that you could do this just because I was able to do. I don't want to promote saying that you could also do. Ideally, it has to be as a team. A doctor, the nephrologist, or a therapist, or an exercise therapist should be working as a team to guide each individual. And that goes even in the normal world, normal healthy individuals also. The same protocol has to be followed. And as you cover the general aspect, general guidelines, where 30 minutes exercise, guidelines, cardiovascular, basic resistant training, a lot of work has to be done on the cardiovascular aspect, which I recommend is a lot of breathing exercise, normal, regular breathing. Instead of doing Kapalabhati, where we normally get into pranayam, simple breathing exercise techniques is good enough and useful enough to start the journey of physical activity. Thank you.
I think that's something I didn't cover, yoga in patients with CKD. Yeah.
Because it's very important in our country, because a lot of emphasis is done in yoga, which is a complete package when you look at the aerobic strength and your cardiovascular aspect.
Thank you.
Aditya?
Thank you, Dr. Kritika Mohan, for the talk, and the chairpersons, Mr. Sumir Kumar and Dr. Indura, for chairing the session. Moving on to the next session, which will be a quiz by Dr. Anita and team. Dr. Anita is Senior Consultant Nephrologist at Apollo Hospitals, Bangalore, and Managing Trustee of Adarsh Institute of Integrated Nephrology Sciences, Bangalore. I request Dr. Anita and team to take over for the quiz for dialysis technicians and nurses.
Okay. Thank you for the introduction. We'll be going ahead with the quiz competition now. Let me introduce my team. Parimala and Santosh will be assisting me with the quiz. And we have had the teams. I'll be reading out the teams for you. Amit and Balaji will be in group A, Bhargavi and Girish group B, Kamal and Maniarasan in group C. Are the participants there?
Yes, ma'am, I'm there.
Shall I start the questionnaire now?
Yes, ma'am.
Yes, ma'am. Are you able to see my screen?
Yes, ma'am.
Am I audible also clearly?
Yes, yes.
Shall we
Yes, ma'am.
proceed?
Yes.
Kindly put this screen on a slide mode. Yeah. Now it is
Yeah,
okay.
I've started it. Okay. Welcome all for this quiz competition. We have the World Kidney Day coming up, and that is the reason why we have all the programs going on. We'll have a short quiz. We will have 4 rounds. We will have 1 question per team. This is the multiple choice questions, and we will give you 15 seconds per question. And we will rotate among A, B, and C teams. If the answer is not given or if there is a wrong answer, we will move on to the next question. Correct answer will get a 10 marks. And if the past question and the next team is answering, it will be 5 marks for them. Then we will have one round of true or false, and which will be given only 5 seconds to answer. Correct answer will get a 10 marks and wrong answer will get a negative 10 marks. That is, negative marking is there. Answer only when your turn is there. All of you please unmute yourself and keep your videos on if possible. And finally, the quiz master's decision will be final. Shall we start?
Yes, ma'am.
Okay. Team A. All the following are functions of a normal kidney, except
You have option D.
who answered?
Ma'am, Balaji, ma'am.
Okay.
Excretion of excessive
Answer is
amounts of proteins.
Okay,
Yes, ma'am.
that is correct. Next question.
Thank you.
All the following are kidney diseases except team B.
Ma'am, answer is D. Sugar in urine.
Okay, that is correct. Next question is to team C. All of the following are common causes of acute kidney injury, except team C.
Option C, E, ma'am, cystine kidney.
That's correct. Next, we will go to the second round. This question is to team A. All the following are common symptoms of kidney disease, except.
Option D, ma'am.
Wrong.
No symptoms.
Wrong. Next question. This is for team B. All of the following can cause kidney failure, except.
Ma'am, answer B.
Can you repeat that? What was the answer?
Answer B. B.
D. D or B?
B.
B. Wrong.
B, ma'am. B.
B is wrong. The second one you mean, correct?
Second one, ma'am. Second one.
That is
Option.
wrong. Wrong.
From C
Next
team, we can
question.
answer, ma'am.
Next question is to team C. Which is the cheapest treatment for kidney failure?
Prevention, ma'am.
Oh, okay, that's correct. Okay, let us go to the next round. This is to team A. These patients should be referred to nephrologist early so that we can do some prevention of progression of chronic kidney disease that can be useful for the patient, except.
Yes, ma'am. Option B.
B.
Option B.
That's correct. That's
EGF for
correct.
more than 90.
Next
Yes,
question. All of the following dietary advice will help preventing progression of chronic kidney disease, except. This is for team B.
Option D, high protein diet.
That's correct. Next question is to team C. Diet and exercises are useful because of the following reasons, except.
Option A, ma'am. Serum creatine level reduces.
That's correct. Next, we go to the next round. We will complete it and finally we will give you the marks. Okay. We will go to team A again. In India, all of the following relations are accepted as near relative for live related kidney, except.
Option E, cousins, ma'am.
Okay, that's correct. Next question. This is to team B. In relation to cadaver kidney donors, which one of the following is illegal? That means it is not to be done. It's incorrect.
Option D, recipients have to pay the donor family for donating.
That's correct. That's correct. Next question is for team C. In relation to cadaver kidney donor, which one of the following is incorrect?
Option C, ma'am. In India, everyone is a potential donor of organ after death, unless on opposite, I would say I don't not wish to donate. It's
Okay,
option C.
correct. That is correct. Next, we will go to the quick answers. Okay, true or false types answers. Quickly answer. This is team A. Remember, negative marking is there.
False, ma'am.
False. False.
Oh, correct. Team B.
False.
Correct. Team C.
True, ma'am.
True. Correct. Okay. So with this, we have come to the end of the quiz. I made it very short because I knew the time that we had was very little. Can we get the scores, please?
Sure, ma'am. Team C, I've got 50 marks, ma'am.
Okay.
Team A and B, I've got 40 marks.
40 marks each.
Yes,
that is very good. It looks like my quiz was very simple. Looks like everybody has got good marks. But let me go to the answers. Just I'll take 2 minutes for this. I'll give you the reasons for this. See, this protein excretion is actually not a job of the kidney. It is leaking. So actually it is bad for the kidneys. Now, sugar in the urine is again not a disease of the kidney. Diabetes in excess. That means when the sugar levels are very high, then it leaks in the kidney and it damages the kidney. Cysts in the kidney are chronic kidney disease. It's not acute kidney injury. Here, increased urine output also can be a symptom of the kidney disease, but that is rare. The common symptom is reduction in the urine output. So by the time diabetes has kidney failure, their urine output is already reduced. Early on, when the sugar is out of control, yes, they can have polyuria, but that time the kidney disease may not be quite manifest. This metformin, it has to be reduced when there is a kidney failure, but itself doesn't cause a acute kidney injury. Cheapest is prevention because you can give very minimal amount of medications, like how we had throughout this meeting. We have seen how to prevent urinary tract infections, use of diet, use of exercises. All these things can be done very early where the cost is almost nil. So prevention is the cheapest way of treatment for kidney failure. Now, early on, we have seen that EGFR more than 90 actually means there is a good kidney functions. Yes, they don't have to visit doctors, nephrologists, especially for prevention, because this is too early for them. But all the other reasons are necessary where the nephrologist has to be seen early. High protein diet, I'm sure you've already heard the discussion just that went on just now. High fiber diet is good. High protein diet is not necessary because it causes a lot of stress on the kidney functions. Now, serum creatinine does not reduce with diet and exercise, but it improves the quality of life and it improves the blood pressure and sugars. So indirectly, it helps prevention of progression of kidney disease. In the transplant, as you already said, cousins are not considered as near relatives, but they can still donate. They have to go through the authorization committee. Now, recipients do not have to pay for organ donated. Many a times we don't even tell them who the donor is. They don't even know who the donor who has donated the kidneys or any other organs for that matter. In India, we still have opt-in policy. There are other countries wherein there is opt-out policy, which means all are considered as donors until they themselves says, I do not want to donate. The abbreviation for E is estimated, it is not evaluated. vascular access is created much earlier so that we can use it by the time they come to 5D stage. That means where they require the dialysis, so that we can avoid the IJC or the temporary catheters. Hypertension, yes, it is very common with kidney disease. There is salt and water retention. That's the most common cause for hypertension in kidney failure patients. Now, we have gone through so many sessions. So just trying to abridge it, diabetes and hypertension are very common cause of kidney failure in India. We as dialysis associated personnel, we would like to inform or spread the correct information to the people. We have to promote prevention, very early prevention, that is early detection of diabetes, hypertension, and keep them under control is important. And kidney disease can be asymptomatic, that we have to remember that. And so detecting them, it is very important. To detect, we can use simple measures like urine routine and creatinine, and we can prevent the progression of kidney disease if we detect them early. Educate the patients or even their relatives about the options available. Take away the fear related to the treatment and stop villainizing the transplant programs. We have seen many people, even in the social media, villainizing it. Recently, we heard somebody say, I will sell a kidney and get money. That, I think, making a mockery of a transplant program is wrong. And all of us need to discuss the good results of dialysis and transplant to other people, so that they understand what the dialysis and transplant for what it means to the kidney patients. And we should promote pledging of the kidney donation after death. That means you pledge that you can be a donor, taken as a donor when after death. So kidney health for all is indeed important. It should be for all of them. Thank you all. And I thank the organizers for giving me an opportunity for conducting a quiz like this.
Thank you so much, ma'am, for giving us opportunity to participate in the quiz. And it's not a simple program to coordinate online like this. It's a great effort from your side, ma'am. Thank you so much for motivating our staff also, dialysis staff.
Yes, I always call my team as the extended arms for us.
Thank you, ma'am.
Thank you. Thank you, ma'am.
Welcome.
Thank you, ma'am.
Thank you, Dr. Anita and team, for hosting the wonderful quiz, and all the participants who have actively participated in the quiz. Thank you for joining us. I'd like to invite Dr. Gauri Satish to propose a vote of thanks for this program.
Good afternoon, everyone. Am I? Hello.
Yes.
Honorable guests, esteemed speakers, ladies and gentlemen, as we come to the end of this wonderful event, it is my privilege to deliver a vote of thanks on behalf of the organizers. First and foremost, I would like to express our heartfelt gratitude to our distinguished guests and speakers, Dr. Maitri Shankar, Dr. Saurabha Rajanna, Dr. Suma Raju, Dr. Kristin George, Dr. Kritika Mohan, and our chairpersons, Dr. Sundar Shankaran, Dr. Renuka Satish, Dr. Padmanabhan, Dr. Shankar Prasad, Dr. Anil Vasudevan, Dr. Sanjay Srinivas, Dr. Sridhara CG, Dr. Tapoti Mukherjee, Dr. Pooja Prabhu, Dr. Mayura Trivedi, Dr. K.S. Nayak, Dr. Manjunath Shetty, Dr. Sumir Kumar, Dr. Arvind Sianji, and Dr. Itu Rao for gracing this occasion with their presence and sharing their knowledge and insights with us. Your contributions have been invaluable in making this event a success, and we are truly grateful for your time and effort. I would also like to thank and for taking the time to join in. I would also like to thank our Secretary, Dr. Maitri, and our Executive Committee members, Dr. Kritika, Dr. Saurabha, Dr. Kristin of Karnataka, whose tireless efforts and hard work have ensured that everything went smoothly. I would also like to thank Dr. Urmila Anand, Dr. Manjusha Yadna, Dr. Manisha Sahai, Dr. Swarnalata Gudidi, the leaders of Green India, for this wonderful initiative. Finally, I would like to express my gratitude to all of you, our audience, for your participation and support. We hope that you have found the event informative and enlightening. Once again, thank you to everyone involved in working this event a success. We look forward to your continued support and participation in our future endeavors too. Thank you and have a good day.
Thank you so much, Dr. Gauri. That was a really extended vote of thanks. Thanks a lot. I think we'll stop the session now. Rajkumar?
Yes, ma'am, we can close the session now.